Hello to all of you. Good evening to all of you. So, good evening, sweetie. Good evening, Ipsita. Good evening, Simran. Good evening to all of you. Okay, so my voice is fine at your side. Is it properly audible? My voice is fine at your side. Kindly confirm it so that I will start the class. Okay, that's great. That's great. So, we will be starting the today's class, and today we will be discussing about this glands, and then we will be going towards the neck portion. Okay, in the neck we will be discussing the deep cervical fascia, the carotid sheath, the triangles of the neck, and the various muscles which are present in the neck. So we will be discussing those all structures, and after that we will be going to the other structures towards the extraocular muscles or towards the oral cavity or nasal cavity. So that we will be going later on, but first we will cover the portion of the neck, and then after that we will go to that portion. So coming to this parotid gland, when we are talking about this parotid gland, over here if you see, let us see this picture over here. Now this is the parotid gland which is present just below the external equistic meatus and just above this angle of mandible. This is a structure which is present over here termed as parotid gland, and when we talk about this, it is a pyramidal shaped structure, and you can see the apex is pointing downwards and the base is present upwards. Okay, and now when you take a section over here, or let us see for one more thing, the apex is over here, the base is over here, then it is having an anterior border. So this will be the anterior border and this one will be the posterior border. Fine. Now to see the other components, we will take a section over here. So if I take a cross section at this level, if I take a cross section at this level, it will appear like this. It will appear like this. So what is in this, you can see the anterior and the posterior border is the same over here, and apart from this you will see on the inner aspect the medial border. Fine, this is the anterior border, this is the posterior border which we can see already in the gland, and in the deeper aspect you have the medial border. Now over here we will talk about the surfaces. The surface which we can see over here, this surface. Okay, the surface which is on the outer side, this is given the term as the superficial surface. So this is the superficial surface, and then apart from this, the surfaces which are on inner aspect for the parotid gland. So between the anterior and the medial border, you have the surface anterior medial surface, and between the posterior and the medial border, you are having this posterior medial surface. So these are all parts of the parotid gland. And when we are talking about the parotid gland, what are the structures which are related to these parts? So what are the structures which are related to these parts? So as to understand this, first of all, I will just explain you that when we talk about the facial nerve is coming and it is passing through the parotid gland, and within the parotid gland it divides into divisions like this. It divides into 5 divisions. This one is the temporal zygomatic buccal, which divides in the upper and the lower buccal. Then we have this marginal mandibular and cervical. Okay, now if you see the upper branches over here, all these branches, they are emerging from the anterior border, and this last branch over here, this cervical branch over here, it actually goes towards the apex. It is going towards the apex. So these are all branches, and we say the anterior border, the upper, all these branches, they are emerging from the anterior border, and only the lowermost branch, that is the cervical branch, is coming from this apex. It is related to the apex. So this is about the facial nerve. And now when we talk about the vein, we know the superficial temporal vein from here, It combines with the maxillary vein to form a retromandibular vein. So within the gland, you are having a vein which is given the term as retromandibular vein, which divides into two divisions. Okay, it divides into two divisions. So the retromandibular vein is within the gland. If I talk about the relations, it's two divisions which divides into two divisions. Okay, it divides into two divisions. So the retromandibular vein is within the gland, and if I talk about the relations, its two divisions are over here at the apex. It is at the apex. And if I see towards the upper side, so at upper side you are having this superficial temporal vein, and this is related to the base. Okay, this is the base. This is the base. So it is related to the base. Fine. Apart from this, we say that within the parotid gland, we are also having a artery which is external carotid artery, and this will further divide into the superficial temporal and the maxillary. Fine. So within the parotid gland, you are having three structures. Within the parotid gland, you are having three structures. I said facial nerve, then retromandibular vein, and the external carotid artery. They are running through the gland. And now when I talk about the relations over here, let us see the relations. So if I say that this is the base, this is the apex, then we are having this as anterior border, this is anterior border, and this one is posterior border. Okay, so what are the structures which are related to it? The base is, let us see over here, the base is related to what structures? It is related to superficial temporal vessels, auriculotemporal nerve, external equestic meatus. Okay, these are the structures related to the base. And when I come towards the apex, apex is related to anterior and posterior division of retromandibular vein and the cervical branch of the facial nerve. So these are the structures related to apex. Now coming to the anterior border. The anterior border is related to all these structures. Okay, it is related to all these structures over here. What are these? Temporal branch, then we have zygomatic, upper buccal, lower buccal, marginal mandibular branch of the facial nerve. Then we have the transverse facial artery and this parotid duct. All these structures, they are related to the anterior border. For the posterior border, we are having these structures which is posterior auricular nerve and vessels. Okay, so these are related to the posterior border. Now, so as to see the medial border, we will have to take a cross section. So this is an image showing the cross section, and in this cross section, this is the medial border, and the medial border is actually towards the wall of the pharynx. Okay, so the medial border is related to the wall of the pharynx. So these are the relations of the border, and then we have also talked about what are the structures passing through the parotid gland. So you can see through the parotid gland you have this facial nerve, this retromandibular vein, and this external carotid artery. And if you see from superficial to deep, okay, this is the superficial side and this is the deeper side. So from superficial to deep, it is facial nerve, retromandibular vein, and then the external carotid artery. These are the structures which are related to it. Now, apart from this, we will say that what are the structures which are in relation to the surface. Now, if I talk about the superficial surface, we very well know that over here you will be having the skin, then you have the superficial fascia, and the deep fascia is present over here. So the fascias are present, and so if you see the superficial surface, this is the superficial surface. It is related to the skin, to the deep cervical fascia. Then apart from this, it is also related to great auricular nerve, okay, great auricular nerve, and the lymph nodes as well as the platysma muscle. Okay, so on the superficial side, you are having all these superficial structures, and the great auricular nerve, we know it is coming and supplying this angle of mandible, the area over here, and as well as the lymph nodes are present. So all these structures, they come in the superficial surface relations. Now apart from this, we are having other relations. So now for other relations, now if I say one surface is this is the anterior medial surface, and another surface is this one, this is posterior medial surface. Now if I see in the anterior medial surface, we know that towards the anterior side of the parotid gland, what structure is present over here, which bone? It is the ramus of mandible. Okay, so the ramus of mandible will be there in the anterior relation and along with the muscles which are attached to it. So what you see over here, ramus of mandible. On the outer side, you are having masseter. On the inner side, you are having medial pterygoid. So just remember the ramus of mandible is in its anterior relation. And if I go for the posterior medial surface, so for the posterior medial surface, if I say what is posterior to the parotid gland, okay, so over here you are having the mastoid process. As you go posteriorly, mastoid process and the styloid process. So just remember mastoid process, styloid process. And if these are in the relation of the posterior medial surface, so the structures which are attached to it, okay, the muscles which are attached to the styloid process and the muscles attached to the mastoid process, like we have this sternocleidomastoid and posterior belly of digastric. So these are the specific relations. These are the specific relations for this parotid gland. Okay, so let us first of all mention all these points and then we will go further. Okay, then we will move further. So first of all, we have started with this parotid gland. And when we are talking about the parotid gland, we have said that it is having parts in which apex, base, 3 borders, 3 surfaces are there. And if I talk about their relations over here, so in the relations regarding the apex, okay, for the apex, what are the relations over here? So in the apex we have cervical branch of facial nerve, then anterior and posterior division of retromandibular vein. Fine. So these are the relations in the apex. Then coming to the base is related to auriculotemporal nerve, superficial temporal vessels and external equistic meatus. Now coming to the borders, anterior border. Regarding the anterior border, so when we talk about this anterior border, for the anterior border we are having the structures in relation which are, you are having facial nerve branches. Okay, the facial nerve branches are there. What branches? Temporal, then you have zygomatic, upper and lower buccal, and as well as marginal mandibular. Okay, all these branches. Then apart from this, we have transverse facial artery and parotid duct. Okay, all these structures related to anterior border. And if I talk about the posterior border, then the posterior border is related to posterior auricular nerve and vessels. Okay, it is related to it. And if I say medial border, for the medial border we say it is related to wall of pharynx. It is related to the wall of pharynx. Now coming to the surfaces, the superficial surface, now for the superficial surface we say it is related to skin. Then we are having this superficial fascia, the superficial and deep fascia, platysma, all these structures. Then we have parotid lymph node and great auricular nerve. Okay, the great auricular nerve. So it is related to all these structures, superficial surface. Then apart from this, anteromedial surface. When we talk about this anteromedial surface, it is related to ramus of mandible, and apart from this, masseter and medial pterygoid muscle. Okay, so these are on the anterior medial surface. And when we talk about the posterior medial, for the posterior medial surface, it is related to, we have said, mastoid process, sternocleidomastoid. I am writing SCM for sternocleidomastoid. Then posterior belly of digastric. Then you have styloid process and structures attached to it. Fine. So all these structures, all these are the relations of the parotid gland. Now after this, we have discussed that what are the structures which are passing through parotid gland. Structures, now this is important, passing through the parotid gland. I am writing in short as PG, parotid gland, and it is from superficial to deep. So when we go from superficial to deep, it will be first of all facial nerve, then you are having retromandibular vein, and after that you have this external carotid artery. Okay, so these are the structures which are passing through the parotid gland. And then apart from this, we say, when we are talking about the parotid gland, we say the parotid gland is enclosed, it is enclosed by fibrous capsule. Okay, so the whole of the gland, it is actually enclosed by a capsule, a fibrous capsule which is contributed by these deep fascia. And now what is the significance of this? So what happens if there is any disease or inflammation or swelling of the parotid gland, so it does not get space to expand. So if I say the parotid gland is like this and it is surrounded by this fascia, so now if there is any swelling, it will not get space to expand and it leads to painful situation. Okay, so that situation is very painful in the cases of any parotid abscess or swelling like in the mumps. So this is a clinical significance over here. So that is why we say the parotid swellings. Parotid swellings, they are very painful. For example, in abscess or mumps, and the pain, when the pain is over here, the pain, it is due to the nerve which is auriculotemporal nerve. Okay, so this pain is basically, we say when the fibrous capsule is stretching over here and the pain over here is due to this auriculotemporal nerve. So the situation over here is very painful when any swelling or any inflammation is there in the parotid gland, because it is covered by a fibrous capsule which is of unyielding nature. Right. Now another important aspect is that for the parotid gland, the parasympathetic supply is by otic ganglia. Okay, so that will be supplying or responsible for the secretion of the gland. So for the otic ganglia, we will be discussing the whole of this otic ganglia later. So in that, I will be discussing the otic ganglia, that how it is responsible for this secretion of the saliva, or we say the secretomotor supply or the parasympathetic supply of the parotid gland. Now over here we will talk about this parotid duct. The parotid duct is also known as Stenson's duct. It is also known as the Stenson's duct. Now this is very important over here, this parotid gland duct. So I am putting a tick over here. It is very important. And when we are talking about this parotid duct, it actually emerges from the anterior border. Okay, it is emerging from the anterior border. So if you go over here, if you see this gland over here, this is the gland. I will just focus it more. This is the gland, and from its anterior border, can you see this duct over here? This one. Okay, so this is the parotid gland duct which is emerging from the anterior border of this gland, and then what happens as it reaches over here, it pierces the structures over here and it goes inside. So it pierces this muscle over here which is the buccinator, then the buccal pad of fat, and as well as the buccopharyngeal fascia over here. And then it goes deeper. It opens in the vestibule of mouth near the upper second molar tooth. Okay, it opens near the upper second molar tooth. Now the point where it is opening or the location where it is opening is very important, not only for parotid duct, also for the other ducts. So this is, you can very well see over here, if the duct will open over here, it is opening towards this upper aspect. Okay, so you remember it is on the upper side and slightly on this posterior, so upper second molar tooth. So it is opening near the upper second molar tooth. So when we are talking about this parotid gland duct, we say it pierces. It pierces BBB. What is BBB? I will just tell you, so easy to remember, BBB. So BBB is buccinator. It is the buccinator, buccal pad of fat, and buccopharyngeal fascia. Okay, so it is B, B, B. 3 B are there, and remember that this muscle is important, that it is piercing this buccinator muscle. Okay, because sometimes they ask you if they are piercing the masseter or the buccinator, it is actually piercing the buccinator muscle. Then after it pierces, now it will open. It will open where? It will open in vestibule of mouth near upper second molar tooth. Okay, so it will open over here. This is very important over for you, that where it is opening, upper second molar tooth. Okay, it is opening near this upper second molar tooth. This is the opening of the parotid duct. Very important. Where does it open? Now for the parotid gland only, we are having a clinical picture which is related to it, and that is the Fraze syndrome. The Fraze syndrome. Now what happens in the Fraze syndrome? Actually, it is usually seen, it is seen after the parotid gland surgery. It is seen after parotid gland surgery. And what is actually there, it actually over here what happens actually is that there is injury to auriculotemporal nerve. The injury of auriculotemporal nerve. Now this is very important, that what nerve is injured over here. So there is injury of auriculotemporal nerve. So what happens when we say over here that during the parotid gland surgery, after the parotid gland surgery, what happens that in this during the surgery, this nerve can be injured, that is the auriculotemporal nerve. And now when this nerve regenerates, its fibers, they actually deviate and go to the nearby, it goes to the other fibers also. And what is the result over here is that, so let us understand what happens when you eat something. Okay, when you eat something, what happens, the parotid gland, it will produce salivary secretion. Okay, it will give the salivary secretion, and now this salivary secretion is by the parasympathetic pathway through the otic ganglia, in which the auriculotemporal nerve is helping. Okay, the auriculotemporal nerve is helping in that. Now, so this is the function of the auriculotemporal nerve. But now what happens, the fibers from the auriculotemporal nerve, they when they are regenerating, they also go towards some sympathetic fibers which are supplying over here the skin of the lateral portion of the face, right? So now when a person is eating, the auriculotemporal nerve is stimulated and the salivary secretion is there. But apart from that, the other nerves are also stimulated, which is supplying the skin over here. And what happens, the redness the redness on this lateral part of the cheek occurs. Redness, then increased temperature as well as sweating on this lateral part of the cheek occurs. So apart from the salivary secretion, there is redness and increased temperature, sweating in this portion of the cheek. So this is a typical symptom of Fraze syndrome. This is a typical complaint of the Fraze syndrome. So what happens? The patient complains of redness, increased temperature, and sweating in the lateral aspect of cheek when he eats. Okay, so when he is eating, he complains of all these symptoms which appears. So this is typical for the Fraze syndrome. This is typical for the Fraze syndrome. Now next we will be talking about the submandibular gland. Okay, we will be talking about the submandibular gland over here. For the submandibular gland, when we are talking about this gland, it's duct. We say very important structure, it's duct, the submandibular duct. Which is also known as Wharton's duct. It is also known as Wharton's duct. Now this duct opens where? It opens in floor of mouth. Okay, it opens in floor of mouth at sublingual papilla. So let us see where it is open. Let us see this in the image. Okay, now this is the picture of the floor of the mouth. If you see this floor of the mouth, you just lift the tongue, and on this lower aspect you are having this floor of the tongue. So this is the tongue over here, and if you lift the tongue, this is the floor of the mouth. Okay, this is the floor of the mouth. So if you lift the tongue, you can yourself see in the mirror, like in the center you are having a fold which is given the term as the frenulum over here. This is the frenulum, and on the side over here, these are the folds which are given the term as sublingual fold. Okay, these are given the term as sublingual fold. These are the sublingual fold, and on the medial aspect of the sublingual fold over here, there is a papilla which is given the term as sublingual papilla. It is given the term as a sublingual papilla. Right, now what happens? The submandibular gland duct, it is opening into this, specifically into this sublingual papilla, which is present over here. And when we are talking about the sublingual gland, when we talk about the sublingual gland opens at this sublingual fold. So over here we have mentioned this sublingual papilla, that the Wharton's duct is opening at the sublingual papilla. Then apart from this, when we are talking about the submandibular gland, as the name suggests, it will be just over here, just near this lower border of the mandible. Okay, so its location will change, or it will come over here at this point. Now when we are talking about the submandibular gland over here, you can see this picture. In the submandibular gland, we say it is divided into two parts, superficial part. You can see it is divided into a superficial part and a deep part with the help of this muscle, and this muscle is mylohyoid muscle. This is a mylohyoid muscle which is actually forming the floor of the mouth. Okay, this mylohyoid muscle, it forms the floor of the mouth, and it is dividing it into superficial and the deep parts. So one thing is this. Now if I say that this is the superficial part, okay, this is on the outer aspect of the mylohyoid, then the deeper part is on its inner side. This is the deeper part. And over here you can see this gland which has been shown over here, this gland, this is the sublingual gland. I will just focus again. Yes, now this gland which has been shown is the sublingual gland, and just above it over here, this is the mucosa of the floor of the mouth. Okay, so it is just near to the floor of the mouth. The sublingual gland, it is just near the floor of the mouth. Now let us see other structures, like we can see the relations. Let us see the relations of the submandibular gland. Now if we see in this image, this is actually, sorry, okay, if we see this image, this is the image which is actually showing the relations of the submandibular gland over here. And if we say that what are the structures which are related to it on the outer side, okay, or on the lateral side. So if we say that this is the gland over here, so on the lateral side it is related to this ramus of mandible, and apart from this the other structures are the medial pterygoid muscle which is on the inner side of the mandible, and this artery which is the facial artery. This is the facial artery, and it is covered over here by this deep cervical fascia. It is the investing layer of the deep cervical fascia. So these are on the lateral side or on the outer side, these relations. And when we talk about the deeper relations, so for that we can see this image. Now for the deeper relations, so if we talk what are the structures which are related to the deeper aspect of submandibular gland. So first of all, let us see this picture. Now if you see, this is the deep part, okay, this is the deep part, or we can say these are the structures which are related to the medial aspect of the gland, which are towards the deeper aspect of the gland. Now what are these structures? Let us see what are these structures. First of all, you are having these muscles. This muscle over here, this muscle which is present over here is hyoglossus, okay, this is the hyoglossus. Then the muscle which is on the anterior side over here is the genioglossus. Apart from this, you can see this nerve which is coming, hypoglossal nerve. The nerve which is coming from above, this one is lingual nerve, and the lingual nerve is related to this ganglia which is submandibular ganglia. So it is related to all these structures, right? It is related to all these structures. And apart from this, for that other relations, let us come to this image. And apart from all these structures, it is also related to more structures. Now what are the more structures? One is this nerve which is glossopharyngeal nerve. This artery is there which is lingual artery. Then we are having this muscle which is going over here. You are having this muscle over here which is styloglossus muscle, and one more muscle which is going over here which is stylopharyngeus muscle. So it is also related to all these deeper structures. So these are the structures which are in the deeper aspect. So you can say that they are in the medial relation of the submandibular gland. And over here, very important for you is hypoglossal nerve, lingual nerve. Then you are having this submandibular ganglia which are on the deeper aspect. Okay, now coming back to this image, we have said that the duct, the submandibular duct, it was opening where? Okay, we said it was opening in the floor of the mouth, and it was opening at the sublingual papilla, right? So if you see this picture over here again, this is the gland, this is the gland, and this is its duct. Can you see the duct over here? This is its duct. Now this duct is, you can see, is opening towards the floor of the mouth. It is opening at the floor of the mouth, and it is opening at the sublingual papilla. So now coming back over here, when we are talking about this submandibular duct or the Wharton's duct, we have already mentioned that it is opening at the floor of the mouth, that is at the level of sublingual papilla. Then apart from this, the other points regarding the submandibular gland is, we say it is a J-shaped structure, and it is having superficial and deep part. It is having superficial and deep parts, and it is divided by a muscle which is mylohyoid. Okay, it is divided by this muscle which is mylohyoid, which we have just seen. Then apart from this, when we are talking about the relations, in the relations for lateral relations, when we are talking about the lateral relations, so we have said that it is related to mandible, medial pterygoid, and facial artery. Okay, we have said that it is related to all these structures, the facial artery. this relation is important, that it is related to the facial artery. Facial artery is actually like winding over the submandibular gland. So it is related to the facial artery. Then coming to the medial relations, that is on the medial side, or we say on the deeper side. So now on the deeper side, it is related to important structures like we say mylohyoid muscle. Then we are having hyoglossus. Then apart from this, it is related to styloglossus. We have mentioned other muscles also like stylopharyngeus. So stylopharyngeus. And apart from this, it is also related to posterior belly of digastric. Fine. So you can see it is related to these important muscles over here, and very important is this mylohyoid and hyoglossus, styloglossus, and apart from this stylopharyngeus, posterior belly of digastric. All these muscles, they are lying in the deep relation or the medial relation. Then apart from this, it is related to important nerves. Now what important nerves? One is lingual nerve, hypoglossal nerve, fine, it is related to submandibular ganglia. So these are the three important structures to which it is related. Then apart from this, it is related to glossopharyngeal nerve and as well as mylohyoid nerve and vessels. So these are the deeper relations over here. All these are the deeper relations. Now apart from these relations, we will let us talk about the other relations also. If I say superficial relations, if I talk about the superficial relations, now what is the structure in the superficial side? So just imagine if I say superficial, superficial is this one. Okay, so you will be having skin, fascias over here. Then apart from this, there is a branch of facial nerve which is coming over here, which is the cervical branch of the facial nerve and the facial vein. The facial vein is on the superficial relation. Okay, it is on the superficial relation. So when we are talking about the superficial relation, we are having skin, superficial fascia, deep fascia and platysma. All these structures are already present over here in the neck, and apart from this you are having facial vein, you have submandibular lymph node also and the cervical branch of facial nerve. Facial vein, an important relation over here. The facial vein is on the superficial side and the facial artery, we have said it is on the deeper aspect, but it is on the lateral aspect. So this is the lateral side, this is the superficial side. Okay, superficial side, lateral side means that it is related to the mandible, and on the medial side it is related to the deeper structures. Now these are the main relations of this gland, and apart from this we say the deep part of the gland, it is also related to the structures like hyoglossus. It is related to these important structures: hyoglossus, lingual nerve, hypoglossal nerve, submandibular ganglia. Okay, it is related to all these important structures, the deep part of the gland. Now important relation over here is that when we are talking about the important relation or for the submandibular duct, when we are talking about the submandibular duct, just give me a minute. Okay, when we are talking about the submandibular duct, we say that it is also having an important relation. When it is going forward, it is crossed by or it is arched by the lingual nerve. So it is related to the lingual nerve. This is an important relation of the duct. So the submandibular duct is related to lingual nerve. Fine. This submandibular duct is related to lingual nerve, and apart from this we say that there is a clinical aspect which is related to the gland. If the gland is excised, or if there any surgery is done, then there is a nerve which can be injured, and that nerve is which is running just along this lower border of mandible, which is marginal mandibular nerve. Okay, marginal mandibular branch of the facial nerve. So when we are doing this excision of submandibular gland, like we do it for tumor or calculus, then in that case there can be injury of a nerve, there can be injury of marginal mandibular branch of facial nerve. Right, this nerve can be injured over here. So this is regarding the submandibular gland, and now next we will be coming to the sublingual gland. Next we will be coming to the sublingual gland, and now when we talk about the sublingual gland, let us go back to the image over here. Okay, now over here if you see in this image, this is the sublingual gland. Okay, this is the sublingual gland, and we basically say the sublingual gland is present just below the mucosa of the oral cavity. And to what structures it is related? So we say it is present actually between this ramus of mandible, the ramus of mandible which is present over here, and this muscle which is genioglossus. The genioglossus muscle fibers, they are running medial to it. Okay, so these are the fibers of the red colored fibers which I have shown. These are the fibers of the genioglossus. So this gland is actually between this mandible, the ramus of mandible, and the genioglossus muscle. And if I talked about the duct over here, that how the duct is opening, so for that let us come to this image over here. So when we talk about the submandibular, this sublingual gland, if I say this is the sublingual gland, then the sublingual gland, it is having multiple ducts which are opening into the sublingual fold. Okay, they are opening into the sublingual fold, and there can be one duct which can join the submandibular duct also. Okay, so it is having multiple ducts. It is having multiple ducts which open at the sublingual fold. So when we are talking about the sublingual gland over here, when we say what are its relations, so for the relations we say on its lateral side we have mandible, and on its medial side we have genioglossus. Okay, and on the superior side you are having this oral cavity, so you can say mucosa of floor of mouth, it is on the superior aspect. This mucosa, just a second over here please, I'm just correcting it, it is the floor of mouth superiorly. Okay, so superiorly the floor of the mouth is there, and when we say it is lying on which structure, so we have already mentioned it was just deep to the mylohyoid. So on the inferior side you are having the mylohyoid. And if I talked about the duct over here, the sublingual duct, it opens at floor of mouth at the sublingual fold. Okay, it is opening at the sublingual fold. And now when we are talking about this duct over here, we say that it is having multiple ducts, in which the main duct, the main sublingual duct, the main sublingual duct is also known as duct of Bartholin. Okay, it is also known as duct of Bartholin. And when we talk about the multiple ducts, the multiple duct is known as duct of Linnaeus. Okay, it is also known as the duct of Linnaeus. So this is about the sublingual gland. This is about the sublingual gland. Fine. Now after this we will be moving on to the neck portion. So we have just covered the glands over here. For these glands, the parasympathetic pathway we will be covering in the when we will be talking about the parasympathetic ganglia. If we talk about the inferior alveolar nerve over here, that how it is related to the submandibular gland, we say that the inferior alveolar nerve basically it enters the mandibular foramen and then it runs in the mandibular canal. Okay, after that it gives off the branches within this mandibular canal. So it is actually present within this ramus of the mandible, within the mandibular canal. Only the mylohyoid nerve it comes out. So when it comes out, it is when it is running in the mylohyoid groove. So over there it is related to the submandibular gland. So inferior alveolar nerve is not in a direct relation to this gland. Now coming to the next. Okay, now coming to the next component, which is the neck. Okay, now we will be talking about the neck portion. In the neck portion we will be talking about this deep cervical fascia first of all. Now when we talk about the deep cervical fascia, we know that it is divided into 3 layers: investing, pretracheal, prevertebral. Fine. And now when we say what are these layers, we say see Prerna, like it is not in a very direct relation with the submandibular gland. So its branches can be injured, but because it is not in a direct relation, so less chances for the inferior alveolar nerve to be injured. If you have any question which is related to it, so we can like discuss that question. We can see, because according to the question also the points they change. Okay, you can send that question, so we will see that question. Okay. So when we are talking about the deep cervical fascia, we say that it is having 3 layers. One is the investing layer. The investing layer is the one which covers the whole of the neck. Okay, it covers the whole of the neck. So when we say the fascia which is covering the whole of the neck like this, it is the investing layer. Okay, like this it is covering the whole of the neck. It is the investing layer. And when it is covering over here, it encloses the muscles. On the anterior side, it encloses the sternocleidomastoid. On the posterior side, it encloses the muscle trapezius. As well as this fascia, it goes in the upper portion of the neck, it encloses the submandibular gland as well as the parotid gland. So we can say that there is a rule of 2. It is enclosing two structures, 2 muscles, 2 glands, and also it has 2 spaces. One is the suprasternal space over here, another is the supraclavicular space, which is formed by this layer only. Then apart from this, we are having this pretracheal layer. The pretracheal layer is basically enclosing this gland, which is thyroid gland. This is the thyroid gland, and it is present just in front of this trachea over here. So that is where the pretracheal layer. Then we are having the third layer, which is present over here. This is the third layer, which is in front of this prevertebral and the paravertebral muscles and the vertebral column. So we say that it is basically enclosing these pre and the paravertebral muscles over here. So these are the 3 layers. These are the 3 layers of the deep cervical fascia. And when we are talking about these 3 layers, over here, yeah, over here only, you can see there is a structure which is formed at this point. Now this is given the term as a carotid sheath. Okay, this is the carotid sheath. Now this carotid sheath is mainly contributed by pretracheal and the prevertebral layers, and this is, you can say, a contribution from the deep cervical fascia. And this carotid sheath, if you see, it is enclosing the major vessels, the major neurovascular bundle, which is on the lateral aspect of the neck. So what are the structures which are enclosed by this carotid sheath? So if you see this picture over here, in this picture you can see the carotid sheath. It is covering these important structures. Now what important structures are covered by carotid sheath? Vein, which is internal jugular vein. Then you have artery, This is the common carotid artery. When it divides into internal, so the internal carotid, it remains inside the sheath, and the external, it comes out. And then a very important nerve over here, which is the vagus nerve. Okay, so all these structures, they are enclosed within the carotid sheath. Okay, they are enclosed within the carotid sheath. Now we say that whatever fascias, whatever layers are there of the deep cervical fascia, they enclose certain spaces. Okay, they enclose certain spaces. Like one space is over here, which is the pretracheal space. Okay, this is the pretracheal space, and you can see in this yellow color, the pretracheal space over here. So when we are talking about this pretracheal space, we say that it is present between which layers. So for this space, one layer is coming like this, and another layer is posterior to it over here. So the layer which is on the anterior side is this investing layer. So I will just focus it more. This is the investing layer, and the layer which is on posterior side over here, this is the pretracheal fascia or the pretracheal layer. So this space is basically enclosed between these two layers, investing and the pretracheal fascia. Then apart from this, we are having the spaces which are towards the posterior aspect. So we have the prevertebral space, and there is a prevertebral space over here. Yeah, there is a prevertebral space over here. Now when we talk about the prevertebral space, as the name suggests, it will be in front of the vertebral column. So what is that prevertebral space? For that, let us first of all, let me mark it. Okay, now let me mark this structure over here. This is the prevertebral fascia, and this one is the buccopharyngeal fascia. So I will just focus it over here. You can see that these two structures have been marked: prevertebral fascia or the layer, and the buccopharyngeal fascia. And towards the posterior side, this is the vertebral column. Now we say there is a blue space over here. There is a blue space over here, which is prevertebral space. Okay, prevertebral space, which is in the front of the vertebral column. So we say the blue colored area, the prevertebral space, is between the vertebral column and the prevertebral fascia. Fine, right? Now coming to another space, which is retropharyngeal. This one is the retropharyngeal space. The yellow colored space which has been shown over here, again I am showing you this this yellow colored space is the retropharyngeal space. Okay, this is the retropharyngeal space. And now when we talk about this retropharyngeal space, it is between these two layers. And now what are these two layers? We can see very well. On the posterior aspect, you have the prevertebral fascia, and on the anterior aspect, you are having this buccopharyngeal fascia. Okay, the buccopharyngeal fascia is actually covering this the pharyngeal portion. So these are the two fascias which between which you are having this space, that is a retropharyngeal space. So these are the various spaces which are between the layers of deep cervical fascia. So when we are talking about the deep cervical fascia over here, for the deep cervical fascia, when we are talking about this, we say that it is having three layers. Now for the three layers, first of all, the investing layer. And for the investing layer, we say the rule of 2 is there. The rule of 2 means that it encloses two muscles. The two muscles are sternocleidomastoid and trapezius. Then it encloses two glands. It includes parotid gland and the submandibular gland. Then it encloses two spaces. Okay, it encloses two spaces. Now what are the two spaces? It is the suprasternal space and supraclavicular space. Okay, so these are the structures which are the important structures for this investing layer. Then the next is pretracheal layer. Now when we are talking about this pretracheal layer, for this we say it encloses thyroid gland. Okay, it encloses a thyroid gland, and apart from this it is actually having a specialized structure, that is ligament of Berry. The ligament of Berry. Now when we are talking about this ligament of Berry, now what is this? This ligament is actually between, it is between the thyroid gland and cricoid cartilage, or we say it can also extend till thyroid cartilage. Okay, so it is over here. See Prerna, like the question which you have sent over here, I will just discuss this question. So pretracheal layer, the ligament of Berry, it is between the thyroid gland and the cricoid or the thyroid cartilage. Now due to this reason, what happens whenever the deglutition process is there and the cartilages, the laryngeal cartilages, they move, the thyroid gland will also move along with it. So that is why we say you can say the thyroid gland, it moves along with larynx during the deglutition process. Okay. Now the third is your prevertebral layer. Now when we talk about this prevertebral layer, we have said that it encloses prevertebral and paravertebral muscles along with the vertebral column. Okay, along with the vertebral column. Now coming to the spaces over here, we have talked about three spaces. What are the three spaces? First is the prevertebral space. First is the prevertebral space, and when we are talking about this prevertebral space, it is between the first is, let us mention that pretracheal space. Okay, the one which is on the anterior side, let us first of all mention that pretracheal space. Now this pretracheal space, we say it is between the investing layer and pretracheal layer. Fine, it is between this investing layer and the pretracheal layer. The second space which we have mentioned is the prevertebral space. The second was prevertebral space, and now this prevertebral space was between the vertebral column and the prevertebral fascia. When we were discussing the carotid sheath over here, this was the carotid sheath. There is, like, if I take a cross section, of the carotid sheath, I will just visualize this image. In this, you can see this is the carotid sheath over here covering all these structures. Now this is the anterior side, this is the posterior side. Now on the anterior side, it is related to these important structure, which is ansa cervicalis, that is the nerve loop, and towards the posterior side you are having this important structure, which is the sympathetic trunk or the sympathetic chain. So these are the important relations, and always remember that these two structures, they are outside the sheath. Okay, they are not inside, they are outside the sheath. Coming to this question over here regarding the structures, like the question which you have sent is the structures which are not injured by submandibular gland excision. So it is not injured. So over here, if we see, the lingual nerve is related, hypoglossal nerve is related, marginal mandibular branch is also related. So thereby the answer of this question will be infioalveolar nerve. So it says not injured, okay, because infioalveolar nerve is not in direct relation to this gland. Now further we will be moving on. We have talked about the deep cervical fascia, and we have also talked about these spaces. Now let us move on to the rest of the portion of the neck over here. We will be talking about the muscles of the neck, in which we will first of all talk about platysma, then we will talk about this sternocleidomastoid and the other muscles. Now if I see, this is the platysma muscle, and if you see how is the origin is like this from below and then it goes upwards. So origin is from this area, which we say which we can say the skin of, you can say upper the upper portion of the pectoral region. Okay, you have this pectoral region over here. So the skin and the fascia of the upper aspect of the pectoral region, from here the origin of the muscle fibers is occurring, and then the fibers, they are running throughout the neck area over here, covering the whole of the neck and reaches the lower border of mandible. So this is the platysma muscle. Okay, this is the platysma muscle. And another muscle over here is this sternocleidomastoid muscle. Now when we talk about this sternocleidomastoid muscle, its fibers are also going like this, like origin is from below and the insertion is towards the upper aspect. Now when I talk about the origin, if you see towards the lower side, you are having two heads, sternal head and the clavicular head. The sternal head takes origin from the upper aspect of the sternum, which is given the term as manubrium. Okay, it is given the term as manubrium. Let us see the origin over here. Yes, this one. And when I talk about the clavicular head, it takes origin from this medial part of the clavicle. Then both the parts, they merge together. And then they insert at this location. So if we see the insertion over here, let us see the insertion over here. It basically inserts on this mastoid process, right, on the mastoid process, and as well as over here, which is the superior nuchal line, the lateral part of the superior nuchal line. So this is the origin and insertion of this muscle, and very important over here is its nerve supply, which is spinal accessory nerve. Very, very important. Spinal accessory nerve is supplying it. So now this muscle is present towards the both sides. Okay, over here also and over here also, the oblique muscles. Now what happens if I say one muscle contract? If one sternocleidomastoid muscle contracts, what will happen? What will be the action? The action is, if I say one side sternocleidomastoid contracts, it tilts the head to the same side, but it rotates the chin to the opposite side. Okay, so the action is like this. If I say this muscle contracts, it tilts the head to the same side but rotates the chin to the opposite side. So what happens, you can see the face is towards the opposite side. If the contraction is on the right side, the face has turned to the left side. So this is important. So if you remember like action like this, if you just do it yourself, the tilting of head on the same side and the chin rotate to the other side. So the face is pointing to the other side. This is the action of one sternocleidomastoid. If I say both sternocleidomastoid contract, so what happens? The head, it moves forward. Okay, the head, it moves forward like this. So this is about this sternocleidomastoid muscle. So we will be starting with the muscles of neck, in which we have mentioned this platysma first of all. And for the platysma, if I say origin, the origin is the from skin and fascia, the skin and deep fascia of upper part of pectoral region. The pectoral region is basically the upper portion of the chest. Then insertion of this muscle. The insertion of this muscle is at the lower border of mandible. And apart from this, if I talk about the nerve supply we already know is by the cervical branch of the facial nerve, right? The nerve supply we already know. So this is about the platysma, and for the sternocleidomastoid, I will be writing in short as SCM. So when we talk about this muscle, origin is by sternal head as well as clavicular head. Now for the sternal head, we say it arises from sternum. Okay, it arises from the sternum, and in the sternum from manubrium part, and from this clavicular head we say medial part of clavicle, right? This is the origin. And when I talk about the insertion, we have mentioned mastoid process. It is from the mastoid process, and as well as the mastoid process, and as well as lateral 1/3 of superior nuchal line. This is the insertion over here. And now when I talk about the nerve supply, which is very, very important, the nerve supply is by the spinal accessory nerve. Okay, this is one of the cranial nerves, the 11th cranial nerve, the spinal accessory nerve. And this spinal accessory nerve, it also supplies one more muscle, which is trapezius. Okay, it also supplies one more muscle, which is trapezius. Now coming to the action of this muscle, when we are talking about the action of this muscle, we have mentioned that if we say unilateral SCM contracts, if there is unilateral muscle contraction, means only one side muscle contraction is there, then it will lead to the head tilts to same side, and chin rotates to other side. Chin rotates to opposite side. Okay, so you can say that the face is turned towards opposite side. Fine, this is correct. This is clear to you. So this action is important for us. And we say when bilateral, or you can say bilateral, or you can say both side muscles, they contract. So when there is contraction of the both side muscles, that is bilateral means both side muscle, then in that case what will happen for this? In this we say the head goes forward. The head goes forward. So this is the action of the sternocleidomastoid. And apart from this, the sternocleidomastoid is related to a clinical aspect which is given the term as torticollis, also termed as wry neck. And now this is due to spasm of sternocleidomastoid. Okay, so torticollis is basically what, like torticollis in that if spasm of the sternocleidomastoid is there, so the head is fixed like this. You can say कि जैसे कि कहते हैं कि थोड़ा सा neck टेढ़ी हो गई, ऐसा बोलते हैं, मतलब neck टेढ़ी हो गई या उस position में fixed है. So the head of the person will be fixed like this. He will be having slightly rotated kind of neck in this manner, and the face will be turning to some other side. So this is due to the spasm of one side muscle, that is the torticollis or the wry neck. Okay, so now we have just mentioned about this platysma, as well as we have mentioned about this sternocleidomastoid. After this, the rest of the muscles of the neck. In this, we are having suprahyoid muscles. Now, in the suprahyoid muscles, we very well know what are the muscles in the suprahyoid. You know it is digastric. In this, we include the anterior and the posterior belly of digastric. Then you have mylohyoid, genioid, styloid. Okay, in this, the digastric is a very important muscle and you should be knowing all the aspect over here for the digastric muscle, very important muscle. So, I am putting a double tick over here, and whenever we are seeing these muscles, mylohyoid, genioid, styloid, so by the name you can tell what is the origin and insertion. Okay, so in the name itself, the origin and the insertion is hidden. Mylo means coming from the mylohyoid line going to the hide bone, insertion in the hide bone. Genio coming from the genial tubercles going to the hide bone. Styloid coming from the styloid process, stylo, so going to the hide bone. So this is for these muscles, a very easy way to remember its origin and insertion. So now when we see these muscles over here, the suprahyoid muscles, a very important muscle is digastric muscle. Now over here for the digastric muscle, let us see, this is the anterior belly of digastric, and then this one is posterior belly. Fine, this is the anterior belly and this is the posterior belly, and over here in the center you are having this intermediate tendon. Now how the origin is occurring, if you see over here, the anterior belly, the origin is occurring from this location, that is on the inferior aspect of the mandible, and this location over here you are having the digastric fossa. So origin from the digastric fossa, the fibers they go down, inserted to the intermediate tendon. Then for the posterior belly, the origin is occurring from here. It basically occurs from the mastoid process, from the inner aspect of the mastoid process, and again the fibers they go down and they are inserted on the intermediate tendon. Fine. So this is about the digastric muscle. Anterior and the posterior belly, they are supplied by different nerves. Anterior belly is supplied by your mandibular nerve and the posterior belly is supplied by the facial nerve. This we have already mentioned in the hybrid muscles. Now coming to this styloid muscle, when we are talking about this styloid muscle, now for the styloid muscle, as I mentioned, if I say, just see over here, this is the mastoid process, right? And over here you are having this projection which is styloid process. Okay, this is a styloid process. Now if you see, there is a muscle which is attached to the styloid process and it is going to the hide bone. Now this muscle is the styloid muscle. As the name suggests, origin from styloid process, insertion in the hide bone. Fine. Now coming to the other muscles over here, if you see, this is the view like this. Okay, the view is taking like this. Now over here you can see a muscle over here which is mylohyoid. The mylohyoid muscle you can see over here. This is the mylohyoid muscle. This is a mylohyoid muscle. Now the fibers, as the name suggests, mylo. The fibers, they are coming from here and then it is going to the hide bone over here. So it actually comes from, origin is from mylohyoid line of mandible and insertion in the hide bone. And similarly you are having one muscle fiber which is present over here. It is actually present on the both sides, right and the left side. Same is for the mylohyoid. The origin is from the genial tubercles, you say the inferior genial tubercles of the mandible, and then the fibers they go and insert in the hide bone. So that is, you can just by the name of the muscle you can tell that origin and insertion is where. So it is very simple. If you remember this thing, mylo, height, origin pehle hai, fir insertion hai. Genioid, styloid. They themselves tell that what are its attachments. So first of all, we will talk about the digastric muscle. Now when we talk about the digastric muscle, for this we know that it is having anterior belly. For the anterior belly, origin is digastric fossa of mandible. It is a digastric fossa of this mandible, insertion in the intermediate tendon. Okay, the intermediate tendon of this muscle. The nerve supply, its nerve supply is by mandibular nerve, and to be more specific, we have already mentioned this mylohyoid nerve. This is for the anterior belly. Now coming to the posterior belly, when we are talking about the posterior belly, for the posterior belly we say origin is from the mastoid, inner aspect of the mastoid process, and that is actually the mastoid notch. Okay, on its inner aspect the mastoid notch is there, which is a part of temporal bone. Insertion again into this intermediate tendon, and when we talk about the nerve supply is the facial nerve. It is a facial nerve. So this is for the digastric, and this digastric muscle is very, very important. Now coming next to mylohyoid. Now a very important aspect of the mylohyoid is that, which I have already mentioned, that it forms floor of mouth, or you can say oral cavity, right? And therefore so it is termed as oral diaphragm. So this is a very important point, that it forms the floor of the mouth, which I have already mentioned during the submandibular gland, and due to this reason it is known as oral diaphragm. Due to this reason it is known as oral diaphragm. And now when I talk about the origin, it is from mylohyoid line of mandible, insertion is into the hyoid, and nerve supply, when we talk about the nerve supply is the mylohyoid nerve itself, which is a branch of mandibular nerve. Okay, it is a branch of the mandibular nerve. The next muscle is genioid. For the genioid we say origin from the inferior genial tubercles of the mandible, and the insertion we very well say it is in the hyoid. It is in the hyoid. And when we talk about the nerve supply over here, it is directly getting the supply from C1. Okay, directly gets the supply from C1, that is a ventral ramus of C1. Next is styloid muscle. In this we can very well say origin styloid process, insertion again into the hyoid, and now when we talk about its nerve supply, it is actually supplied by the facial nerve. And now what is the common action of all these muscles? The common action is it helps in elevation of the hyoid, and as well as it helps in depression of mandible. Okay, so this is the common action which is done by these suprahyoid muscles. Now quickly we will talk about the infrahyoid muscles also. When we talk about the infrahyoid muscles, in the infrahyoid muscles, what muscles are included? We are having omohyoid. Now this is an important muscle. Then apart from it, thyroid, sternohyoid, sternothyroid. Okay, so now over here also, if you see these three muscles, the origin and insertion is accordingly. The thyroid, then we say this sternohyoid and sternothyroid. The origin and insertion, like we say the attachment of the muscle is according to its name. Thyroid, we say its origin is from thyroid cartilage and then it comes to the hyoid bone. Sternohyoid means origin from the sternum, then it comes to the hyoid bone. Similarly for the sternothyroid. And now let us first of all see these muscles over here. Okay, so these are the infrahyoid muscles, and if I see in the infrahyoid muscles, let us just see the muscle over here. One muscle is present over here. Okay, this muscle is between the hyoid bone and this is the thyroid cartilage. This is the thyroid cartilage. So it is going from the thyroid cartilage to the hyoid bone. So this muscle will be thyroid. This is the thyroid muscle. Then there is a muscle which is going from the sternum over here and then it is going to the hyoid bone like this. So this is the sternum towards the lower side and from here it is going to the hyoid bone. So this will be the sternohyoid muscle. This is the sternohyoid muscle. Then there is a muscle going from the sternum and then to the thyroid cartilage. So this will be the sternothyroid. So this is according to its name. Now coming to the muscle that is the omohyoid. Now for the omohyoid, let us see this picture. Now the this omohyoid is having two bellies. One is this belly, another is this belly. And this is the intermediate tendon. The superior and the inferior belly is there. This is the superior belly and this one is inferior belly. Now when we talk about the inferior belly, it actually takes origin from scapula. Okay, towards the posterior side you are having the scapula. Over here it takes the origin and then comes above. Origin from over here, the scapula, then the muscle fibers, they run above, they form the intermediate tendon, then they form the superior belly, and finally they are having the insertion, or you can say they are attached to this hyoid bone. So this is this whole omohyoid muscle. And we have already mentioned that this infrahyoid muscle, they are mainly supplied by which nerve loop? Ansa cervicalis. It is supplied by the ansa cervicalis. So let us talk about this omohyoid muscle first of all. Now for the omohyoid, we know that we have just mentioned that for the omohyoid, the inferior belly, it arises from, it actually arises from scapula, its superior border. Then the fibers, they continue to form intermediate tendon and then its fibers, they continue to form superior belly and finally inserts on hyoid. Okay, so this is for the muscle as a whole. This is for the muscle as a whole, and when we talk about its nerve supply, it is supplied by ansa cervicalis. Now coming to the next muscle, sternohyoid. For the sternohyoid, as the name suggests, you can tell origin from sternum, insertion hyoid, and nerve supply. I am just writing the initials over here, the ansa cervicalis. Okay, we have already mentioned it is supplied by ansa cervicalis. The next muscle is sternothyroid. For the sternothyroid, as the name suggests, origin sternum, insertion thyroid cartilage, and when we talk about the nerve supplies, it is ansa cervicalis. Right. Now the next muscle is thyroid. Now for the thyroid, again I say origin thyroid cartilage, insertion hyoid, and now over here nerve supply, we say it is directly supplied by C1. So it is supplied by ventral ramus of C1. It is supplied by the ventral ramus of C1. And over here, if I talk about their common action, so they basically help to depress. They basically help to depress the hyoid bone. Okay, they basically help to depress the hyoid bone, and apart from this, the action of thyroid. This is a common action which is done by them, and apart from this, we are having an important action of thyroid, and that action is that it actually helps in elevation of larynx, which is during the deglutition process. Okay, so these are the actions which are performed by these infrahyoid muscles. These are the actions which are performed by these infrahyoid muscles. And now let us quickly just talk about there are few other muscles also, that is the scalene muscles. Okay, we will just quickly talk about this and then we will take a break. So when we talk about the scalene muscles, these are the muscles which are present towards a deeper aspect. I will just show you. Okay, now this is the image which is showing the scalene muscles. You are having scalenus anterior, medius and the posterior. Now the scalenus anterior muscle, if you see, it is taking origin from here and then it is going like this. So you can clearly see that it is taking origin from transverse process of C3, C4, C5, C6, and insertion is on first rib. And on the first rib over here specifically, this structure is given the term as scalene tubercle. Okay, there is a projection over here termed as scalene tubercle. Now this scalenus anterior muscle is important because it is having important relations. Now what are its important relations? If I say this is the muscle over here, this is the muscle over here, the scalenus anterior. So on its anterior side, this is the structure which is running on the anterior side. You can see it is a vein. It is the subclavian vein. The subclavian vein is running on the anterior aspect of the muscle and towards the posterior aspect. So this is on the anterior aspect. Towards the posterior aspect over here, you are having the subclavian artery and this nerve plexus over here, which is the brachial plexus. Fine. So these are the structures which are in relation to this scalene muscle and scalenus anterior muscle. And apart from this, you can see there is a nerve which is coming over here from above. You can see this nerve which is coming here from above. This is the phrenic nerve. So the phrenic nerve also you can say that it is on its anterior aspect. So this is an important relation for the scalenus anterior. Now coming to the medius. This is the medius. We say this is the largest muscle of the three. And if you see the origin is from the transverse process of C2, C3, C4, C5, C6, and the insertion is again over here on the first rib. Okay, on the first rib. Let us see the scalenus posterior. For this origin you can say from the transverse process of C4, C5, C6, and now where it is going, the fibers, they are going to the second rib. So the anterior and the medius, they insert on the first rib and the posterior it is inserting on the second rib. So when we are talking about these scalene muscles, for scalenus anterior, okay, this is the first muscle over here. When we are talking about this muscle, we say origin is from transverse process of C3 to C6 and the insertion is in the first rib, that is on scalene tubercle. This is important that insertion is on the first rib on the scalene tubercle for the scalenus anterior muscle. And apart from this, when we talk about the relations over here, over here, so anteriorly this muscle we have said it is related to subclavian vein. Okay, it is related to subclavian vein and along with it phrenic nerve. Posteriorly it is related to subclavian artery and brachial plexus. So these are the important relations over here. You should be knowing these relations also. So among these three muscles, the scalenus anterior muscle is the important muscle. So I'm just putting a tick over here. This is the most important muscle. Then coming to the second muscle, which is scalenus medius. For the scalenus medius, origin from transverse process of C2 to C6 and we say it is the largest muscle over here among the three. And when I talk about the insertion, it is on the first rib. The third muscle is scalenus posterior, and now for this we say origin is from transverse process of C4 to C6, and now over here insertion is on second rib. So you should be knowing that its insertion is on the second rib. Okay, anterior and the medius, they are inserting on the first, and the third is inserting over here on the, this scalenos posterior is inserting on the second rib. Now let us have a quick break over here. Let's have a break over here till 7. Okay, let's have a quick break over here till 7, and then we will continue further. Okay, so we are back from the break. And before the break we have started with the neck portion, in which we have talked about the deep cervical fascia, carotid sheath. Then we have discussed about these muscles, all the muscles of the neck, like platysma, which is covering the neck, then sternocleidomastoid, the suprahyoid muscles and the infrahyoid muscles. Right, now after this we will be moving on to the triangles of the neck. And now when we talk about the triangles of the neck, okay, now when we talk about the triangles of the neck, we know that there is one anterior triangle, another is the posterior triangle. Okay, so anterior and the posterior triangle, how they are there? We say that on the lateral aspect of the neck you are having which muscle? Sternocleidomastoid. Okay, this is the sternocleidomastoid muscle, and this muscle, which is obliquely running, it divides the lateral aspect of the neck into anterior triangle. So you are having this anterior triangle over here, and on the posterior side, posterior triangle. Now how the anterior triangle is there and how the posterior triangle is there, so we will go by one. First of all, we will talk about the anterior triangle, and then after that we will come to the posterior triangle. Now for the anterior triangle, let us focus over here. If I talk about this anterior triangle over here, if I say this is the anterior triangle, right, this is the anterior triangle. So now in the anterior triangle, on the posterior side, which muscle is there? It is sternocleidomastoid. On the anterior side we say it is the midline of the neck. Okay, it is formed by this midline of the neck. So it is the midline of neck on the anterior side, and on the superior side, what is present over here? This is a bone, which is the mandible, the lower border of mandible. So these are the boundaries of your anterior triangle. And now this anterior triangle is further subdivided into 4 more triangles. Let us see how. So if I say this is the anterior triangle, so you can see within the anterior triangle there is one muscle which is V-shaped muscle over here. This is a V-shaped muscle, and this is the digastric, anterior and the posterior belly of digastric. Then you are having, this is the superior belly of omohyoid. Okay, this is the superior belly of omohyoid, and this omohyoid it runs below like this. It is running below like this. So in the anterior triangle you are having superior belly of omohyoid. Now these structures over here, these 2 muscles, digastric and the omohyoid, they have divided it into further 4 triangles. Now what are the further 4 triangles? Let us see that. Now if you see the further 4 subdivisions, now in the further 4 subdivisions, one triangle is present over here. This is one triangle, right? And now this triangle is carotid triangle. This is a carotid triangle. Then there is a triangle which is on the upper aspect over here. This is another triangle. This is given the term as submandibular triangle, also termed as digastric triangle, because it is between the 2 bellies of the digastric. Then there is third triangle which is present over here. This is just below the chin, so it is given the term as submental triangle. This is the submental triangle. And the third triangle is over here, which is present on the anteriormost side. and now this is given the term as muscular triangle. Okay, this is given the term as the muscular triangle. So you are having these 4 triangles, 4 subdivisions over here. So we will go one by one for each of the 4 subdivisions. So when we are talking about the triangles of neck, for the triangles of neck, first of all we are starting with this anterior triangle, and in the anterior triangle what are the boundaries? In the boundaries we say posteriorly you are having sternocleidomastoid, superiorly you are having lower border of mandible, fine, lower border of mandible, and anteriorly you are having midline of neck. Okay, so these are the boundaries of this anterior triangle. These are the boundaries of anterior triangle, and then further we say what are its subdivisions. So these boundaries are important for us. We should be knowing that what structure is forming which boundary. Then subdivisions, again this is important, subdivisions of anterior triangle. Okay, subdivisions of anterior triangle. And now over here we say what are the subdivisions? It is subdivided into carotid triangle, submandibular, also known as digastric, okay, so these are the subdivisions of anterior triangle. And now when we are talking about this anterior triangle, for this we talk about the roof of anterior triangle as a whole. So when we are talking about the roof of anterior triangle, it is actually formed by, if you say this is the anterior triangle, so the roof will be formed by the skin, fascias, the superficial and the deep fascias, and the platysma muscle which is present over here. And in the deep fascia, it is basically formed by the investing layer of the deep fascia. So this is a roof for all the anterior triangles, the complete anterior triangle. So we say all the subdivisions of anterior triangle, the roof will be same. Okay, the roof is same for all the subdivisions. So it is same for all subdivisions. The roof is same for all subdivisions, and in the roof we say it is formed by skin, superficial fascia, you have platysma, and then you have investing layer of deep cervical fascia. So over here this investing layer of the deep cervical fascia is contributing into the roof. It is contributing into the roof. Fine. So because it is the most superficial structure over here, it is covering the whole of the neck. So it is contributing into the roof over here. Now going to each triangle one by one. First of all, we will talk about the carotid triangle, right? Okay, first of all, we will talk about the carotid triangle. So let us come to the carotid triangle. This is the carotid triangle. If I just come back over here, we have already seen over here that this is the carotid triangle. Can you tell the boundaries over here? Now for the boundaries over here for the carotid triangle, on this posterior side, this is the posterior side, which muscle is there? This muscle is sternocleidomastoid. Okay, this is on the posterior side. Let me use some other color. On the posterior side, you are having this muscle, sternocleidomastoid. Then on the superior side, anterior and superior, over here, the anterior and the superior aspect, it is formed by which muscle? It is formed by this posterior belly of digastric. Okay, this is on the anterior and the superior side. Then on the anterior and the inferior side over here, it is formed by superior belly of omohyoid. So these are the structures or the muscles which are forming the boundaries of this carotid triangle. So if I again see the boundaries over here, this is the posterior side, this is the anterior side. So on the posterior side, you are having this muscle sternocleidomastoid. This is the triangle over here. Okay, this is the triangle over here. And on the anterior and the superior side over here, this is the posterior belly of digastric. It is formed by this posterior belly of digastric, and on this anterior and the inferior side, it is formed by superior belly of omohyoid. So these are the three muscles. These are the three muscles which are forming its boundaries. The carotid triangle is important for you. You should be knowing all the three boundaries. Now coming next is the muscles which are forming the floor. So over here you can see the various muscles which are forming the floor. The main muscle over here you can see is one, this muscle, another is on the lower side. Now what are these muscles? Let us see. One muscle is this middle constrictor of pharynx, another is inferior constrictor. Okay, so above middle constrictor, this one is inferior constrictor. Then apart from this, the other muscle is, one muscle is over here. This is the hyoglossus. This is the hyoglossus. Another muscle is present below over here, this small muscle over here. This is thyroid. Okay, this is the thyroid. So these are the four muscles which are contributing into the floor. Mainly the constrictors on the anterior side, hyoglossus, thyroid. These are the muscles which are contributing into the floor. Now coming to the contents. Now the word is carotid artery, or the carotid triangle. Now the word carotid triangle is there because in the contents you are having the whole of this carotid arteries which are present over here. So you can see common carotid artery over here dividing into this external carotid and internal carotid. So this is one of the contents over here. You have this vein, internal jugular vein, and along the vein you are having these deep cervical lymph nodes. Then in between you are having this nerve which is going, this is vagus nerve. So these three structures they are enclosed by the carotid sheath present over here. On the anterior aspect of the carotid sheath you had ansa cervicalis, posteriorly sympathetic trunk. So they also come in this contents over here. Now apart from this, apart from all these structures, you also have one nerve which is going like this. This is hypoglossal nerve. Another nerve which is going like this, and this one is spinal accessory nerve. The ansa cervicalis, it is a nerve loop which is present over here. So all these structures in the carotid sheath, around the carotid sheath, and along with these other nerves, they form the contents of carotid triangle. So it is very easy to remember the carotid triangle contents. Simply remember the carotid sheath, its contents, its relations, and spinal accessory nerve. They are in the triangle contents. Simply remember the carotid sheath, its contents, its relations, and apart from this, hypoglossal nerve, spinal accessory nerve. They are in the contents of the carotid triangle. So now when we are talking about this carotid triangle, first of all let us talk about the boundaries. First of all let us talk about the boundaries. In this, first of all, on the posterior side you have sternocleidomastoid. The carotid triangle is important as such. Then anterior superior side, it is having posterior belly of digastric. The posterior belly of digastric, and then towards the anterior inferior side. Then towards the anterior inferior side, it is formed by superior belly of omohyoid. Then coming to the floor, in the floor we are having these main muscles, that is middle and inferior constrictor. Then we have mentioned thyroid, and as well as we have mentioned hyoglossus. Then coming to the contents, now when we are talking about the contents over here, in the contents we first of all let us write carotid sheath, common carotid, external carotid, internal carotid artery, internal jugular vein, along with it deep cervical lymph node. Then you have vagus nerve, ansa cervicalis, sympathetic trunk, the sympathetic trunk, and apart from this you have hypoglossal nerve, spinal accessory nerve. So these are the contents of this triangle. Now next we will talk about digastric triangle. Now coming to the digastric triangle, okay, now this is the image which is showing the digastric triangle which is present between the two bellies of digastric. Okay, so the digastric triangle is present like this between the two bellies of digastric. So if you see this muscle over this triangle over here, on the anterior side you are having anterior belly of digastric, on the posterior side you are having posterior belly of digastric, and towards the superior side you are having lower border of mandible. These are the boundaries over here of this triangle. These are the boundaries of this triangle. And now when we talk about, if I say this is completely the triangle in this manner. Now if I talk about the muscles which are forming the floor, so you can see on the most anterior side this muscle is present which is mylohyoid. Then posterior to it this muscle is present which is hyoglossus. So these are the two muscles which are mainly forming the floor, and apart from this a very small contribution by middle constrictor. So these are the muscles which are forming the floor. If I talk about the contents, so if I talk about the contents, we know that in this triangle the submandibular gland is present along with the submandibular lymph nodes. So this is the submandibular gland which is present over here. This is the submandibular lymph nodes. Then apart from this, it is related to this artery over here. This artery is facial artery and this vein is the facial vein. So it is related to all these important structures. And apart from this, we say it is also related to this hypoglossal nerve which is running like this. It will be going like this over here. So it is related to the hypoglossal nerve also. So you can see that all these structures, they are present within this triangle. So they form the contents of digastric triangle. So when we are talking about the digastric triangle, first of all, the boundaries. Now for the boundaries, we have said on anterior side you are having anterior belly of digastric, on posterior side posterior belly of digastric, on the superior side lower border of mandible. Okay, so these are the structures forming the boundaries. Then in the floor we have mentioned mylohyoid, hyoglossus, and one more muscle, middle constrictor. Fine. And now when we talk about the contents, we are having an important structure which is submandibular gland. The submandibular gland, this is an important structure present over here. Then apart from this, submandibular lymph node, facial artery and vein, and also hypoglossal nerve. Okay, so these are the important contents of this triangle. These are the important contents of this triangle, and after this we will be talking about submental triangle. Now the submental triangle is just below the chin, and we say that it is between the two anterior belly of digastric. So when we are visualizing from the anterior side, Let us go back over here. Over here we have mentioned this segmental triangle. So when we are seeing this triangle from the anterior side, we just see only the half portion, and so as to see the complete segmental triangle, we should see it from the anterior side. So this is the anterior view, and this red colored triangle which has been shown over here, this is the segmental triangle. And now when we talk about the segmental triangle, it is between the two anterior belly of digastric. This is also anterior belly, this is also anterior belly. So it is between two anterior belly, and the base is formed by this hyoid bone. This is formed by this hyoid bone. And now when we are talking specifically about this triangle over here, so in this image you can see this is the segmental triangle between the two anterior belly of digastric and hyoid. And now what muscle is forming the floor? So you can see this muscle, you are having one muscle over here, mylohyoid, which is forming the complete floor of this triangle. And in the contents you can see there is a vein which is anterior jugular vein, and there are lymph nodes which are segmental lymph nodes. So this is about your segmental triangle. So when we are talking about the segmental triangle, for the boundaries we basically say, for the boundaries we say it is formed by right and left anterior belly of digastric, and apart from this, on the inferior side it is formed by hyoid. So you can say on the right and the left side it is formed by the two anterior belly of digastric. Then regarding the floor, it is formed by mylohyoid, and regarding the contents, it is formed by the segmental lymph node and anterior jugular vein. Okay, so this is formed by these structures over here. This was for segmental triangle. Now next coming to muscular triangle. Now next coming to the muscular triangle. Now if I talk about the muscular triangle over here, we will go back to this image. Coming to the muscular triangle, if I see over here the muscular triangle, let me focus over here to the muscular triangle. Now what are the structures which are forming the boundaries over here? If I see what are the structures forming the boundaries, so we can very well see over here on the anterior side, this is the midline of the neck, right? On the anterior side, it is the midline of the neck. Then on the posterior and the superior side, this muscle is the superior belly of omohyoid, and on the posterior and the inferior side, this muscle is the sternocleidomastoid. So these are the three structures which are bounding the muscular triangle. And when we come to the muscular triangle over here, let us see this picture. Now the muscular triangle is present like this. Okay, this is the location of muscular triangle, and when we talk about the floor, it is formed by the infrahyoid muscles, the sternohyoid, sternothyroid, and the thyroid muscles, which are present in the inferior aspect over here. And these are the one which are actually contributing as the contents also. So this triangle is very simple. For the muscular triangle, we say for the boundaries, when we are talking about the boundaries over here, when we are talking about the boundaries over here, for the boundaries we have already mentioned, it is formed by sternocleidomastoid, then it is formed by superior belly of omohyoid, it is formed by superior belly of omohyoid, midline of neck. Fine, these are the three structures. And when we are talking about the floor, or we can say the contents over here, it is formed by the infrahyoid muscles like sternohyoid, sternothyroid, and thyroid. So this is a very simple triangle over here. In this, among the four, the most important triangle is the carotid. and then the digastric. The carotid and the digastric, these are the most important triangles over here. So this was about the anterior triangle and their subdivisions. Now we will be moving further towards the posterior triangle. Okay, so now we will be moving further to the posterior triangle. So let us come back over here again to this image. Okay, so if I come back over here to this triangle over here, now towards the posterior side of the sternocleidomastoid, you are having this posterior triangle. So when I talk about the boundaries of posterior triangle, on the anterior aspect, it is bounded by sternocleidomastoid. Posteriorly over here, you are having this muscle trapezius, and towards the inferior side, you are having this bone which is clavicle. So these are the three structures which are bounding the posterior triangle. Okay, these are the three structures bounding the posterior triangle. So now again, if I see, that this is the posterior triangle. Now the posterior triangle, if you see over here, it is actually divided by this muscle into two parts. And now what muscle is this? This is inferior belly of omohyoid. This is the inferior belly of omohyoid which divides it into two parts. Upper big portion, it is given the term as occipital triangle, and the lower small portion, it is given the term as subclavian triangle, or also termed as supraclavicular triangle. Now a very important aspect over here is that the floor. Okay, now when we talk about the floor over here, this is the picture which is showing the floor of this triangle. This is the posterior triangle, this is the posterior triangle and the floor. Now the floor is formed by, if you see on above, this muscle is semispinalis capitis, then this muscle is plenus capitis, levator scapulae, this is levator scapulae, and one more muscle over here which is scalenus medius. So these are the four muscles which are actually forming the floor of this posterior triangle. Now coming over here, this is the picture which is showing the contents of this posterior triangle, and you can see the specific contents of each of the subdivision. So let us see the triangle. If I say this is the posterior triangle and this is the subdivision over here by omohyoid. Now the structures which are present in the upper occipital triangle. So you can see the various nerves. The nerves are present like great auricular nerve, then you have transverse cervical nerve, you have lesser occipital nerve, and apart from this you have one more nerve which is supraclavicular nerve. Okay, so these are the nerves which are going in different directions, like this one, this one, this one and this one. These are the four nerves which are present over here. These are the nerves which are coming from this triangle only. Now apart from this, you are having one important nerve which is running through this portion, and that is the spinal accessory nerve, and towards the upper aspect you are having a small artery which is present. This is occipital artery. So all these structures, they are forming the contents of occipital triangle. And now when we come towards the lower side, as the name suggests, subclavian triangle, so it will be having the subclavian vessels along with the brachial plexus. So when we talk about the lower side, you can see this vein over here, we can see a vein, we can see artery, and we can see the nerves over here. The vein is subclavian vein, artery is subclavian artery, and the nerves over here is actually the brachial plexus. So these are the three important structures which are present over here in this subclavian triangle. So these are the important structures over here in the subclavian triangle. Now coming over here for the posterior triangle, let us mention the posterior triangle over here, whatever we have mentioned. Posterior triangle. Okay, its boundaries are important for us. Now over here also for the posterior triangle, we say for the roof, we say it is formed by investing layer of deep cervical fascia. Over here also it is investing layer of deep cervical fascia. And when we are talking about boundaries, the boundaries are important. Over here for the boundaries we say on anterior side sternocleidomastoid, posterior side trapezius, inferior side you have clavicle. Okay, and now coming to the floor, for the floor you were having the muscles splenius capitis. First of all it was splenius capitis, then you have semispinalis capitis, levator scapulae, and then it was the scalenus medius. Okay, so these were the muscles which are forming the floor, and then further we said that we are having the subdivisions. Further we were having the subdivisions. Now the subdivision, how it is there? The subdivision is by inferior belly of omohyoid, and we say it is subdivided into occipital triangle. It is subdivided into occipital triangle, and the another one is subclavian triangle or supraclavicular triangle. Fine, these are the subdivision of this posterior triangle. Now next is contents. Now that we have mentioned they were nerves. In the nerves, the most important nerve is spinal accessory nerve, and along with the spinal accessory nerve we are having the fibers of C3 and C4 nerves also. The most important structure over here, spinal accessory nerve, which is running through this posterior triangle. Then apart from this, the other nerves were great auricular nerve, transverse cervical nerve, lesser occipital nerve, supraclavicular nerve. Okay, all these nerves were there, and towards the upper side we said we had a occipital artery. So we say that all these structures, they were present as content in occipital triangle. Okay, all were present in the occipital triangle, and apart from this, the other contents that were subclavian artery and vein, the subclavian artery and vein, and brachial plexus. These were the contents of subclavian triangle. Okay, these were the contents of the subclavian triangle. So all these were the contents of the posterior triangle. All these were the contents of posterior triangle. Now over here we are having a clinical aspect which is related to the spinal accessory nerve. For the spinal accessory nerve, we say that it is running in the posterior triangle. So if there is if you are doing any procedure in the posterior triangle, like if there is any cut or incision over here in the posterior triangle, it will lead to injury of a nerve, and that nerve is spinal accessory nerve, because it is more superficial and it is a very important nerve. So just note over here that this important thing, if any cut or incision in the posterior triangle, then it will lead to injury of spinal accessory nerve. Okay, so this is an important aspect, that if there is any cut or incision at the posterior triangle, it will lead to injury of a nerve, and that is the spinal accessory nerve. Let us just come back over here. Okay. Okay, so we have done with the triangles of the neck. Okay, we have discussed all these triangles of the neck. Next, we will be talking about the gland which is present in the neck over here, and that gland is this thyroid gland. Okay, this gland is this thyroid gland. Now, when we are talking about this thyroid gland, if you see over here, what you can see is that it is having lobes. These are lobes, and it is connected by a structure which is termed as isthmus. So on the sides, this is lobes, and this one is isthmus. In the center, you are having this isthmus. Now, when we talk about the extent, of the lobe, so you can see this is the extent of the lobe C5 to T1. The vertebral level is C5 to T1. And if I compare it with the cartilages over here, so it extends from this thyroid cartilage to the fourth or fifth tracheal ring. Okay, the tracheal rings which are present over here. Now, talking about the isthmus, this is the isthmus portion. The isthmus portion is lying just opposite to C7. And if I talk about that, it is related to which local structure? So it is related to second, third, and fourth, your second and third, fourth tracheal rings. Okay, so these are the relations, or you can say the extent of the thyroid gland. And when we are talking about the thyroid gland, its artery is very important. Its blood supply is very important. If you see over here in this thyroid gland, you can see the artery is coming from above. This is the artery coming from above. This is superior thyroid artery. And as we have discussed earlier, the superior thyroid artery, it is a branch of external carotid artery. Another artery which is supplying the thyroid gland, it is coming from below. Like this, you can see it is coming from below. And now this artery which is coming from below is inferior thyroid artery. Now this inferior thyroid artery, if you remember, is originating from subclavian artery. In the subclavian artery, we mentioned thyrocervical trunk, and the thyrocervical trunk, its branch is inferior thyroid artery. So these are the two main arteries which are supplying the thyroid gland. Fine, these are the two main arteries which is supplying the thyroid gland. In some cases, one more artery can be present over here. And now when this is present, it is actually given the term as thyroidia ema artery. Okay, it is given the term as thyroidia ema artery, and you can see when it is present, it takes either origin from this arch of aorta, or it can also take origin from this brachiocephalic artery. So thyroidia ema artery, it can take origin from any of these structures. So this is about the artery. The arteries are very important over here for the thyroid gland. And if I talk about the veins, so you can see there are 4 veins over here, 1, 2, 3 and 4. These are the 4 veins, and these are superior, middle, inferior, and this Koch's vein. Now over here, this is the superior thyroid vein. This is the superior thyroid vein, this is the middle thyroid vein, this is the inferior thyroid vein. And the fourth one over here is given the term as the Koch's vein. And if you see the drainage of these veins, the superior and the middle veins, they drain into this internal jugular vein. They drain into the internal jugular. And the fourth vein, Koch's vein, it is also draining into the internal jugular. But if I see inferior thyroid vein, it is draining into this left brachiocephalic vein. So you can see it is draining into the left brachiocephalic vein. Now apart from this, when we are talking about these arteries, like we can say the superior thyroid artery which is present over here, it is coming like this. This is the inferior thyroid artery. So it is actually having important relations. The important relations with nerves over here. What are the nerves? One nerve is present over here. Okay, this is actually the external laryngeal nerve. So we say the superior thyroid artery is related to this external laryngeal nerve over here. And now when we are talking about the inferior thyroid artery, it is related with this nerve. The nerve is coming like this. And this nerve is recurrent laryngeal nerve. So we say the inferior thyroid artery is related to recurrent laryngeal nerve. It is related to the recurrent laryngeal nerve. So these are the important relations of these arteries over here. Then apart from this, we say the inferior thyroid artery. Now this one is the posterior view of the gland. This is the posterior view of the gland, and in the posterior view what we see is there are glands, the parathyroid glands which are present over here. Okay, it is the superior and the inferior parathyroid glands. The superior and the inferior parathyroid glands which are present on the posterior aspect over here. And now you can see this artery which is coming over here. Now this artery which is running like this over here, this is inferior thyroid artery. And this inferior thyroid artery is the one which will supply the parathyroid glands. So we say the supply to the parathyroid glands is by this inferior thyroid artery. The inferior thyroid artery, it gives off parathyroid artery which will supply these parathyroid glands. Okay, so now when we talk about this, thyroid gland over here, let us talk about this thyroid gland. Okay, now for the thyroid gland, we have discussed that the extent, first of all, the extent. Now the thyroid gland is important as a whole. It is important as a whole. And now when we talk about the extent of lobe. The extent of the lobe is from C5 to T1, or we say that it is from thyroid cartilage to 5th or 6th tracheal ring. This is the extent for the lobe. And if I talk about the extent of isthmus, then that is just at the level of the C7, or we say it is opposite 2nd, 3rd and 4th tracheal rings. Okay, so this is the extent of the thyroid gland. And next, coming to its arteries. Now when we talk about its arterial supply, first we have mentioned superior thyroid artery, which is, we have mentioned, the branch of external carotid. It is a branch of external carotid, and this superior thyroid artery, it actually supplies upper 1/3 portion of gland. Okay, it supplies the upper 1/3 portion of the gland. And now next is inferior thyroid artery, which is a branch of subclavian artery. And when we talk about this, now this will supply the rest of the gland. So it supplies lower 2/3. It supplies the lower 2/3 of the gland. Now the third artery over here which we have mentioned is thyroidea ema artery, and when it is present, we say it takes origin from I can say it is a branch of, either it takes origin directly from arch of aorta, or it can come from brachiocephalic artery. It can come from the brachiocephalic artery. So these are for the arteries over here. This is for the arteries over here. Now when we talk about the veins, so it is over here we say that superior thyroid vein, the superior thyroid vein is there, middle thyroid vein, inferior thyroid vein. In this, the first two they drain into internal jugular vein. Okay, the inferior one, it drains into left brachiocephalic vein. The inferior one, it drains into the left brachiocephalic vein, and then we are having one more vein, which is fourth vein of Kocher, and this vein, it will drain into internal jugular vein. So this is about the veins of the thyroid gland, all the four veins and their drainage, right? And then when we talk about the parathyroid gland, the parathyroid artery, which is for parathyroid gland, it is a branch of inferior thyroid artery. Okay, so it is a branch of the inferior thyroid artery. The parathyroid artery, it is a branch of inferior thyroid artery. And apart from this, we have the relation over here which we have mentioned. The superior thyroid artery is related to external laryngeal nerve, and when we talk about inferior thyroid artery, then it is related to recurrent laryngeal nerve. Okay, it is related to the recurrent laryngeal nerve. So these are the important points which is regarding the thyroid gland. These are the important points which are regarding the thyroid gland. Now next we will be talking about, so over here we have talked about this thyroid gland. Now next we will be coming to the parasympathetic ganglia of the head and neck, in which we include ciliary, otic, submandibular, pterygopalatine. Okay, so over here you should be knowing the details of these ganglia, how they are supplying, which gland they are supplying, what is their location, what are it is related to which functional nerves, as well as it is related topographically to which nerve. So everything you should be knowing about these parasympathetic ganglia. So when we talk about the parasympathetic ganglia of this head and neck, the parasympathetic ganglia of this head and neck, so over here we are having the four parasympathetic ganglia, and when we are talking about these four parasympathetic ganglia, like for each ganglia we say it is having parasympathetic root, which is actually secretomotor. Okay, it is secretomotor in nature. What do we mean by this? Secretomotor means that it is responsible for the secretion from the gland. Okay, one is this root. Apart from this, you are having sympathetic root and as well as sensory root. So these are the roots which are commonly present in each of the parasympathetic ganglia, and the important one over here is the parasympathetic root, which is responsible for secretion from the gland. Now when we talk about this parasympathetic root, if I say how this is present, the parasympathetic root, for this I will just mention how it is present. If I say that the nucleus is present in the brainstem. Okay, the nucleus is present in the brainstem, so its fibers will go and end in a ganglia. If I say this is a ganglia, and further the fibers will arise from here and it will reach to any the specific structure where it has to reach. You can say the gland or the specific structure where it will be reaching. Now this is the pathway for the parasympathetic root. The nucleus present in the brainstem, this is a common pathway which is followed. The nucleus in the brainstem, it ends, the fibers they ends in the ganglia, and from their ganglia another fibers they arise from there, and they will now reach to the destination, the gland or any other structure. So now over here, this is, we say that the fibers that relay in the ganglia. Okay, they transfer the impulse in the ganglia. And now the fibers which are before the ganglia, they are given the term as, this is preganglionic fibers. Okay, and the fibers which are after the gland, they are given the term as postganglionic fibers. This is a basic thing to understand over here. So whenever we are talking about preganglionic, it is before the ganglia, and postganglionic, the fibers passing after the ganglia. Because sometimes they can be asked that what are the preganglionic fibers, what are the postganglionic fibers for this specific ganglia. Now next we will be talking about each of the ganglia, and for that a very easy way to remember is by the mnemonic. And now what is a mnemonic over here? Mnemonic is, you will remember the mnemonic in this same format. Okay, you will remember the mnemonic in this same format. COPS. COPS is police. COPS. COPS 3977. Okay, the mnemonic is COPS 3977. And apart from this, you will remember one more thing, NMML. Okay. NML. So you will remember this mnemonic in the same format, COPS 3977 NMML. NML, you can remember by this NML, NMML. So what is actually significance over here? C is ciliary ganglia, or I will just tell you, this first line is for ganglia. This line is for the relation, you can say the functionally related cranial nerve. This is functionally related cranial nerve, and this line is for topographically related cranial nerve. Okay, so by this you can remember very easily. C, ciliary ganglia, functionally related to third cranial nerve, oculomotor, and topographically it is related to N. N is over here nasociliary. Okay, this is nasociliary nerve. Then coming to O, O is otic, functionally related to ninth glossopharyngeal nerve, and topographically it is related to M. M is mandibular nerve. Then next coming to P, P is pterygopalatine. Pterygopalatine related to seventh nerve, that is facial nerve, and topographically it is related to M, that is maxillary nerve. And then we are coming to next, that is S. Okay, over here this one S is submandibular ganglia related to seventh facial nerve, and topographically it is related to L, which is lingual nerve. So by this mnemonic you can remember this very tough thing, because it is really tough to remember the functionally related nerve and the topographically related nerves. This is the best way to remember it. COPS 3977. Always remember COPS 3977 NMML. Okay. So now let us make a table over here. I will just make a table over here. In the table, let us just first of all write the ganglia, then functionally related nerve, topographically related nerve, the topographically related nerve, then its location and structure supplied. The structure supplied. Okay, so I've just made this table over here, and one by one we will be mentioning each of the ganglia. We will be mentioning its nerves, location and the structure supplied. This is an important table because it will help us remember all these important structures. First is ciliary ganglia. First is ciliary ganglia. For this, the functionally related nerve was cranial nerve 3, that is oculomotor nerve. Topographically, N, nasociliary nerve. And when we talk about the location, we say it is in bony orbit, and in the bony orbit it is between the lateral rectus muscle and optic nerve. Okay, it is present between these two structures. And when I say what are the structures which are supplied by it, it supplies muscle which is ciliaris and sphincter pupillae. Now over here we have remembered the nerves, and when we talk about the structures, you can see ciliary, ciliaris. Okay, the name it is rhyming, ciliary, ciliaris. So it supplies the ciliaris and the sphincter pupillae. Then coming to otic ganglia. For the otic ganglia, 9th cranial nerve which is glossopharyngeal, related to topographically related to mandibular nerve. Location, it is found in infratemporal fossa, and it supplies parotid gland. Okay, it supplies the parotid gland. This is for otic. This is for the otic. Now next we come to pterygopalatine. The pterygopalatine ganglia, the cranial nerve was 7. Okay, so over here we know it is the facial nerve. Now in the facial nerve also we say that which specific branch of the facial nerve is helping in this, and that specific branch is greater petrosal nerve. The greater petrosal nerve is a branch of facial nerve, and related to maxillary nerve, where it is present, pterygopalatine fossa. It is present in pterygopalatine fossa. It supplies mainly lacrimal gland. Okay, it supplies mainly this lacrimal gland over here. Then next coming to the submandibular ganglia. The submandibular ganglia, cranial nerve, again 7, which is facial nerve, and its specific branch which is helping in this is cauda tympani nerve. Okay, its specific branch cauda tympani nerve, and we have mentioned it is related to lingual nerve, present where? In submandibular region. And it supplies what structures? It supplies submandibular gland as well as it supplies sublingual gland. So this is for the submandibular ganglion. So this is supplying these all basic structures over here. Now this table is very important because by this table you can remember all this important aspect of the ganglia very easily. So this is the easiest way to remember it. This is the easiest way to remember it. And over the ganglia also is having the same name structure to which it is supplying, that is submandibular gland and the sublingual gland over here. So the structure supplied over here you can remember very easily. Now coming over here, when we are talking about these ganglia, the parasympathetic pathway is the most important. And how it is supplying these structures over here. So we should be knowing the parasympathetic pathways over here for all these ganglia. The parasympathetic pathway for these ganglia, first of all we will say ciliary ganglia. For the ciliary ganglia, now the nucleus for this is Edinger-Westphal. Okay, the nucleus is Edinger-Westphal nucleus, which is termed as EWN nucleus. The fibers from here, they go to oculomotor nerve, then nerve to inferior oblique. The nerve to inferior oblique. Then these fibers, they go to ciliary ganglia. And now from the ciliary ganglia, the ciliary nerves, they come and then they reach to ciliaris and sphincter pupillae. Okay, so this is the whole pathway from the brainstem nucleus to the ciliary ganglia and then to the destination, that is to this muscle. And we will say that these fibers over here, these are the preganglionic fibers, and lowermost over here, these are the postganglionic. Okay, these are the postganglionic fibers. So this is for the ciliary ganglia. Now coming to otic. For the otic ganglia, what is the, over here this otic ganglia is very important. What is the sympathetic pathway for otic ganglia? Now for this we say the nucleus for this otic ganglia is inferior, it is an inferior salivatory nucleus. Okay, it is the inferior salivatory nucleus. So if I say the nucleus for this is inferior salivatory nucleus. Now from here emerges the fibers, they actually go to tympanic branch of glossopharyngeal nerve. This tympanic branch of glossopharyngeal nerve, it is also known as Jacobson nerve. Okay, the fibers, they go to this, then further they go and contribute in the tympanic plexus. The tympanic plexus, which is present in the middle ear at promontory of middle ear. Okay, so the fibers, they go to the tympanic branch of glossopharyngeal, then tympanic plexus. Over here, from this, the fibers, they arise. One of the nerve, it arises, which is lesser petrosal nerve, and this lesser petrosal nerve now will finally go to otic ganglia. Right, it will go to the otic ganglia, and now from the otic ganglia, the fibers which arise, they pass through auriculotemporal nerve, and finally it reaches to the parotid gland. Okay, so this is the whole pathway for otic ganglia, and again if I say over here, these will be the preganglionic fibers, and this one will be the postganglionic fibers, the pre and the postganglionic fibers. For the head and neck portion, like tomorrow we will be having the last class. We will be covering the rest of the head and neck. After today, tomorrow will be the last class. The next is pterygopalatine ganglia. Now for this pterygopalatine ganglia, we say that when we are talking about the pterygopalatine ganglia over here, for the pterygopalatine ganglia, we say when we are talking about this, the fibers, they arise from the nucleus, and that is the superior salivatory nucleus. So the fibers, they arise from superior salivatory nucleus, and these fibers, they actually over here, the superior salivatory nucleus, as well as they also mention one more nucleus, that is lacrymatory nucleus. Now the fibers from here, they pass towards the facial nerve, then towards its branch, which is greater petrosal nerve. Now further what happens, the greater petrosal nerve is joined by a nerve which is deep petrosal nerve. There is a nerve, deep petrosal nerve, which joins it okay, the deep petrosal nerve, it joins the greater petrosal nerve, and it forms Vedian nerve, or we say the nerve to pterygoid canal. This is given the term as Vedian nerve. This is given the term as a Vedian nerve, and now this now this nerve, it goes and it goes towards this pterygopalatine ganglia, and now from the pterygopalatine ganglia, what happens, the fibers, they emerge, and they will go towards they will form the branches which will be supplying the various glands like nasal glands, palatine glands, and the pharyngeal glands. So nasal, palatal, and pharyngeal. The fibers, they arise directly. Then apart from this, the fibers, there are more fibers which arise and they pass through zygomatic nerve, which is actually a branch of maxillary nerve, and this zygomatic nerve, the fibers, they pass through the lacrimal nerve, and finally it reaches to lacrimal gland. Okay, finally it reaches to the lacrimal gland. So this is the whole pathway. Over here, few fibers are also going to nasal, palatal, and pharyngeal glands. So if we see this whole pathway over here, now again we will say towards the upper side, these are pre-ganglionic fibers, and towards the lower side, These are post ganglionic fibers, right? These are pre and the post ganglionic fibers. Now the next ganglia over here is submandibular. The next is the submandibular ganglia, and now when we are talking about the submandibular ganglia, for this again the nucleus will be superior salivatory nucleus, and from there the facial nerve fibers, the fibers are passing through the facial nerve, but which branch? Chorda tympani. So the nucleus is superior salivatory, then to the facial nerve, its branch chorda tympani nerve, and then to lingual nerve, which passes towards the submandibular ganglia, and from here it directly supplies submandibular gland. Few fibers they run again towards lingual nerve, and then they supply sublingual gland. Then they will supply the sublingual gland. So again over here you can just mention that these are preganglionic fibers and these one are postganglionic. These one are the post ganglionic fibers. Okay, now for the pterygopalatine, when we are talking about the pterygopalatine, this is also known as sphenopalatine ganglia. So if anywhere it is mentioned sphenopalatine, that is the same. This one is the same, the pterygopalatine. And apart from this, I will just mention regarding the, for the otic ganglia, we say that it is also having a motor root. Okay, it is also having the motor root. It is also having the motor root, and in this what is there? We are saying that the two muscles, the tensor tympani and the tensor villi palatini, they are supplied. So how they are supplied? We say that tensor tympani and tensor villi palatini, they are supplied by nerve to medial pterygoid. They are supplied by nerve to medial pterygoid, which is a branch of mandibular nerve. Okay, so these two muscles, the two muscles, they are being supplied by this nerve, which is actually a branch of the mandibular nerve. So these are the important points over here for this ganglia. These are the important points over here for these ganglia over here. Okay, now moving further. Okay, now when we were talking about the otic ganglia, I will just show you the location over here. This is a picture which is for the otic ganglia. This is a picture of the orbit. In the orbit, you can very well see this is the optic nerve. This is the optic nerve, and on the lateral side over here, you are having this muscle, lateral rectus. Okay, this is the lateral rectus. Now, in between these two structures, this is the ganglia which is present. Okay, this is the ciliary ganglia which is present over here. So this is the location over here, and now when we are talking about the location of the other ganglia, so let us see this image over here. This is the location of otic ganglia, right? And you can see that it is present just below the zygomatic arch over here, so it is present in the infratemporal fossa. This is the location of pterygopalatine ganglia which is present over here in this pterygopalatine fossa, and this is the location of submandibular ganglia which is present over here in the submandibular region. So this is about these parasympathetic ganglia over here. Okay, now next over here, just give me a minute. Okay, now next over here we will be coming to this extraocular muscles. Okay, next we will be coming to the extraocular muscles over here. Now when we are talking about the extraocular muscles, I will just go back over here. When we are talking about the extraocular muscles, for the extraocular muscles we say that we divide it into, right, sorry, for the extraocular muscles we say that we include in this, what muscles are included in this? We include in this 2 recti, we include in this 4 recti. Okay, the 4 recti are there. In the 4 recti you are having superior, inferior, medial and lateral recti. Then we include 2 oblique, which is superior and inferior, and the third muscle is levator palpebrae superioris. Okay, these are the muscles over here. Then apart from this we are having intraocular muscles also. In the intraocular muscles you include ciliaris, sphincter, pupillae and as well as dilator pupillae. Okay, you include all these muscles. You include all these muscles over here. Now for the extraocular muscles over here, we will be talking about each of the muscle one by one. We will talk about each of the muscle one by one. First of all, we will talk about levator palpebrae superioris. Now for this muscle we say we will be talking about the origin and insertion. When we talk about the origin, we say it takes origin from sphenoid. Okay, it takes origin from sphenoid, from where we say lesser wing of sphenoid. It takes origin from lesser wing of sphenoid, and when we talk about the insertion, it is inserted on the we say the skin of the upper eyelid. Okay, it is inserted on the skin of the upper eyelid, and over here when we are talking about its action, because it is inserted on the skin of the upper eyelid, so therefore it helps in elevation of upper eyelid. So this is about the levator palpebrae superioris, which comes like this, inserted on the upper eyelid. So when it contracts, it elevates the upper eyelid. For this levator muscle, fine. If we see this image over here, what we can see is that this is the lateral view. This is the lateral view over here, and towards the most superior side, you are having this muscle which is levator palpebrae superioris. Okay, the levator palpebrae superioris. From the posterior aspect, it is taking origin from sphenoid. So on the posterior aspect from the sphenoid, if we already have know the picture of the orbit over here, so it is almost taking origin from here, right? And this is the component of the lesser wing of sphenoid. If you remember in the orbit, this is the component of the lesser wing of sphenoid. So it is taking origin from here, and then after that it goes forward, and as it goes forward over here, it is inserted in the upper eyelid. The upper eyelid, it is coming like this. These are the eyelids. So it is inserted in the skin of upper eyelid. So therefore when it contracts, it causes elevation of upper eyelid. Now apart from this, we will talk about the recti muscles. For the recti muscles we say, if we again see this picture over here, we already remember this is optic canal, this is supraorbital fissure, and apart from this we have mentioned that there was a ring over here, the annulus of Zinn. Okay, and this annulus of Zinn is also known as common tendinous ring. Now the origin of the recti muscles is from this common tendinous ring. So you say that the superior rectus, inferior rectus, medial rectus, inferior rectus. Okay, all of them, they are together taking origin from this common ring, that is common tendinous ring, and then they go in their respective directions according to its name. So when we see in this image over here, this is a location of common tendinous ring, and when we talk about the muscle fibers, this muscle which is going over here, this is the superior rectus. Then over here, this muscle which is going over here is medial rectus, and on the lateral side it is the lateral rectus accordingly, and on the inferior aspect will be the inferior rectus. And now when they are going over here, they actually for the insertion they go in front of the equator. So if this is the eyeball, this will be the equator. Okay, for the eyeball this is the equator. So all the muscle fibers, they are going in front of the equator like this, and they are inserted near the limbus. Now what is the limbus over here? For the limbus, we say, if we see this eyeball over here, this is sclera, this is cornea. Okay, the cornea with the transparent portion which is there, and the junction of the cornea and sclera over here, this is given the term as limbus. Okay, limbus. So if you see the muscles, they are going in front over here. These muscles, they are going in front over here like this, and they are inserted near this limbus, that is the corneoscleral junction. So the origin and insertion, this is the origin and insertion of the recti muscles. Now coming to the oblique muscles. When we are talking about the oblique muscles over here, now for the oblique muscle, we say that as the term suggests, oblique, they are going obliquely. And how they are inserted? First of all, let us see the superior oblique. Now the superior oblique muscle, for the superior oblique muscle, we say it takes origin from the sphenoid. Okay, and the fibers are mainly coming from the body of sphenoid. So over here, this muscle over here which is going like this. Can you see this muscle which is going like this? Just deep to it, this one is medial rectus. The medial rectus is going like this. So superior oblique, I will just remove the medial rectus so it does not create any confusion. This was superior oblique, if you see. Now the superior oblique taking origin from here, from the sphenoid, and then it runs forward, and as it runs forward, it takes a turn over here by this fibrous pulley present, and then it comes back. And as it comes back, you can see that it is going behind this equator. So we say the insertion in the eyeball is behind the equator. And due to this oblique fibers which are running over here, we say the action of the muscle will also be slightly different. Okay, the action will also be slightly different. Now talking about the inferior oblique, I come to this image over here. Now over here, the inferior oblique is present over here, starting from here and going like this. This is inferior oblique, starting from the floor of the orbit. Okay, it is taking origin from the floor of the orbit, from this anterior and the inferior aspect of the orbit, and the fibers, they run obliquely, and again we can say that it is going behind this equator. This is the equator. So again the fibers, they are going behind the equator of eyeball for the insertion. So this is about the origin and insertion of these muscle fibers. So we have written about, we have mentioned this levator palpebrae superioris, and next is the recti muscles. So when we talk about the recti muscles, for the recti muscles we say the common origin. The common origin is from the annulus of Zinn. It is from the annulus of Zinn, which is also given the term as common tendinous ring, and this we say it is attached near the apex of orbit. Okay, it is attached near the apex of the orbit. And now when we talk about the insertion of all these muscles, it is anterior to equator, anterior to the equator of eyeball, anterior to the equator of eyeball near limbus. And what is limbus over here? Limbus is corneoscleral junction. Okay, so the insertion is anterior to the equator near the limbus. And now when we are talking about this limbus over here, so we should be knowing the distances of insertion from limbus. What is the distance of insertion of four muscles from limbus? So distance of muscles from limbus. And now for this you can remember by this mnemonic MILS, mils, 5, 6, 7, 8. This is easy to remember in this manner, 5, 6, 7, 8 mils. So the distance of medial rectus, so the distance of medial rectus, it is 5 mm from limbus. It is 5 mm from limbus, so it will be M5, I is 6, L is 7, S is 8. Okay, so medial rectus is 5 mm from limbus, and if I say inferior rectus, it is 6 mm from limbus, lateral rectus 7 mm from limbus, and superior rectus is 8 mm from the limbus. So these are the distances of these muscles from the limbus, and you can remember by this mnemonic mils. You can remember by this mnemonic mils. Now the next muscle is superior oblique. Okay, the next muscle is superior oblique, and when we talk about its origin, we have said sphenoid, body of sphenoid. It is a body of sphenoid and the insertion is behind the equator. It is behind the equator of the eyeball. Now coming to inferior oblique over here. For the inferior oblique, we say the origin, we have mentioned the floor of the orbit. Okay, the floor of the orbit, and we say it is basically anterior medial. It is basically the anterior medial aspect of floor of orbit, and the insertion is again behind the equator of eyeball. It is behind the equator of the eyeball. Okay, so now we will take a quick break over here. Okay, we will be taking a quick break over here, and this break is till 8:40. So let us take a quick break over here, and then we will be talking further about these extraocular muscles. So we have to talk about the nerve supply and as well as the actions of these extraocular muscles. That we will talk about after this break. is the lateral rectus. It is actually supplied by this cranial nerve 6, which is abducent. Okay, it is supplied by the cranial nerve 6, which is abducent, and SO4 we say superior oblique is supplied by cranial nerve 4, which is trochlear nerve. It is a trochlear nerve. So this is a very important point, that these muscles, they are supplied by these specific nerves. This nerve supply is very important. And now next we will be talking about the action of these muscles. So when we are talking about the action of these muscles, for the action we say the medial rectus and lateral rectus. Okay, so they are having one action each only. The medial rectus, it helps in adduction of eyeball, and the lateral rectus, it helps in abduction of eyeball. So when we are talking about the eyeball over here, if I say this is the eyeball over here. When the eyeball, it sees laterally, so that is abduction. When it turns medially over here, so this is adduction. So abduction and adduction movement is there. Fine. And this medial and the lateral rectus, they are having one action each. Now apart from this, there are other actions also. Now what are the other action of the eyeball? So when we are talking about the other actions, for the other action, the eyeball can see up, and this will be given the term as elevation, and it can see down, which is given the term as depression. Okay, it can see up, it can see down. Then it can also have rotatory movements. Okay, it can also have rotatory movements. So when we are talking about the rotatory movements, the eyeball can rotate inwards. It can rotate inwards. Then it will be given the term as intorsion. And it can rotate outwards. It can also rotate outwards, which will be given the term as extorsion. So these are the other movements which can occur, rotatory movements as well as elevation and depression. Now the medial and the lateral rectus, they are having one action each, but when we talk about the rest of the muscles, they are having more than one action, which we can remember by this mnemonic. Okay, we can remember it by this mnemonic. The mnemonic is sin rad. Sin is together and this rad is together. Now what is this sin rad? The sin rad is, sin means superiors intort. Okay, so S is superior, IN is intort. So it means to say superiors intort, and this means recti adduct. So R is recti, AD is adduct. So now for the rest of the muscle, we will be utilizing this mnemonic to tell the actions. So superiors intort means superior rectus and the superior oblique. It will help in intorsion. Recti adduct means now the rest of the two recti, that is superior and the inferior rectus, they will help in adduction. And for the other muscles, it will be the opposite. Okay, so whatever is left, like superiors, they are intort. So now the inferiors which are left, they will help in extorsion. Recti, if they adduct, so the muscles which are left is obliques, they will help in abduction. So by this mnemonic, you can tell the action of the rest of the muscles. We have superior rectus, inferior rectus, then we have superior oblique and inferior oblique. Okay, so these are the four muscles which are left. And before we use this SINDAT mnemonic, the superior rectus, as the name suggests, it helps in elevation, and the inferior will help in depression of the eyeball. But this is opposite in the oblique because the fibers arrangement is slightly different and they are running obliquely. So the superior oblique, it helps in depression. So because it is different, so this becomes important for us, that it helps in depression, and the inferior helps in elevation. So this action is very important. And now we will put this mnemonic over here, sin rad. So let us put this mnemonic over here. We have said sin. Sin means superiors intort. So intorsion I will be adding over here in the superior muscles, that is superior rectus, and in superior oblique. And what is other action? We have written rad, recti adduct. So in the superior rectus I am writing adduction, and as well as inferior rectus I am writing adduction. Now for the rest of the muscles it will be opposite. So extorsion over here, extorsion, and over here you have abduction, and this one is also abduction. So these are the actions which are performed by these four muscles. These are the main actions which are performed by these muscles. Now after this we will talk about the clinical aspect which is associated with these muscles. Now what is a clinical aspect? If I say there is oculomotor nerve palsy. If I say there is oculomotor nerve palsy, now for this oculomotor nerve palsy we say that the most common reason for the oculomotor nerve palsy is compression by a aneurysm of posterior communicating artery. So it is we say this lesion is due to compression by aneurysm of posterior communicating artery, or it can be due to also internal carotid artery. Okay, so this point is important, that it can be due to the compression of this aneurysm of posterior communicating artery. And now what will be the signs and symptoms over here? What will be the signs and symptoms? The signs and symptoms will be, first of all, ptosis. The ptosis is due to the paralysis of levator palpebrae superioris. Okay, the ptosis is drooping of the upper eyelid. It is a drooping of the upper eyelid. Then we are having fixed and dilated pupil, and now this is due to the paralysis of ciliaris and sphincter pupillae. Another symptom over here is downward and outward position of eyeball. The downward and the outward position of the eyeball. And now when we talk about this downward and outward position of the eyeball, it is, we say, due to unopposed action of lateral rectus and superior oblique. So what is actually happening over here? Due to the paralysis of these muscles, these actions, these signs and symptoms are there. And now the down and out position is, all the muscles are paralyzed except lateral rectus and superior oblique. So therefore, due to lateral rectus, the eyeball, it looks outwards, and due to superior oblique, the depression is there, so eyeball looks downward. So downward and outward position of eyeball is there, down and out, due to unopposed action of lateral rectus and superior oblique. And due to all these, we say there is diplopia, which is a double vision. The double vision is there. Then this is the main palsy over here, oculomotor nerve. Apart from this, you can also see abducent nerve palsy. And for the abducent nerve palsy, we say that the reason for this is that because we say the most It is due to increased intracranial pressure. Okay, it is due to the increased intracranial pressure, and we say that most common cranial nerve involved in increased intracranial pressure is abducent nerve. Okay, so if the increased intracranial pressure is there, the most common cranial nerve which is involved is abducent nerve, and when this happens, it will lead to convergent squint. And this convergent squint is basically due to paralysis of lateral rectus and unopposed medial rectus. So what is actually happening over here? We say the lateral rectus over here, it is paralyzed. Okay, the lateral rectus is paralyzed, the medial rectus is active. So what happens? The eyeballs, they converge to the medial side. So the eyeballs, they go medially, as if you are looking towards your nose. Okay, so that is given the term as convergent or medial squint. Another is, you can also see trochlear nerve palsy. And in the trochlear nerve palsy, what you will find is that the person will have difficulty in looking downwards. So the downward movement, the depression movement is mainly by the superior oblique, which is paralyzed. So the patient has difficulty in looking downwards, like he will be like in looking downwards, or you can say in reading newspaper. You can just, this is just an example. For example, in reading newspaper or going downstairs. So the patient has difficulty in looking downwards. So we can say example, I'm just putting over here so that you're not confused. Difficulty in reading newspaper or difficulty in going downstairs. Now this is basically, we know very well, due to paralysis of superior oblique. This is due to the paralysis of superior oblique. So because the depression is affected, the patient is not able to see properly downwards. So like when you are reading something, newspaper, you are not able to see properly. And as well as when you are going downstairs, so you have to look down. So that action is affected. So that is why the patient complains difficulty in all these things. Okay, now next we will be coming to the tongue portion. We will be coming to the tongue portion, and now when we are talking about this tongue portion, for the tongue, portion, we say the tongue is divided into 3 parts. Okay, it is divided into 3 parts. If this is the tongue, then we say it is divided into 3 parts. First is this sulcus terminalis. And just on the posterior aspect of this, you are having this foramen cecum. Okay, this is the foramen cecum. Now we say that the part which is anterior to it, the part which is anterior to the sulcus terminalis, that is the anterior 2/3 part. This is the first part. Then the part which is behind it, it is posterior 1/3 part. Then over here you can say that this portion, this small portion which is present towards the most posterior side, this is the base or posterior most part. So the tongue is divided into these three parts. Okay, these are the three parts of the tongue: first, second, third, and the base is towards the most posterior aspect. Now in the tongue only, we say just anterior to the tongue you are having circumvallate papillae. Okay, these are the big round papillae which are present over here. So we say this is circumvallate papillae, which is, you can very well see, just anterior to sulcus terminalis. Okay, this is just anterior to the sulcus terminalis. So this location is important, that it is anterior to it. Then after we, as we go to, as we see more posterior to the tongue, more posterior to the base, then over here we say that there are folds. Okay, there are folds between the tongue and the epiglottis. There are folds between the tongue and the epiglottis. MLL. I'm writing it as MLL. M is median glossoepiglottic fold. Okay, M over here is median glossoepiglottic fold and L over here is lateral glossoepiglottic fold. Okay, so these are the folds which are extending from the tongue. It is extending from the tongue to the epiglottis, so termed as these glossoepiglottic folds. And between these glossoepiglottic folds over here you are having the depressions, and these depressions over here, they are given the term as vallicula. Okay, these depressions, they are given the term as vallicula. So this is the complete structure of the tongue from anterior to the most posterior side, from the anterior to the most posterior side. Now over here we have mentioned this circumvallate papilla, so we will mention the papillae. The papillae, they are present on the superior aspect or the dorsum of the tongue. They are not present on the inferior aspect. And when we talk about the papillae over here, for the papillae we say that basically there are four types of papillae, in which the one is circumvallate, then you have fungiform, filiform. The fourth one, foliate, it is rudimentary in humans. So mainly these are the first three are the one which are main. Okay, so what are the various papillae over here? So if I talk about the papillae in the tongue over here, so basically they are present on superior aspect of tongue. And if I talk about its types, so what are its types? First is filiform. First is the filiform. The filiform is conical like this. Okay, it is conical like this. So for the filiform we say it is conical in shape, or you can say conical projection, and it is diffusely present in the tongue. It is diffusely present, and it diffusely means that it is present throughout the tongue. It is present throughout the tongue, and this is the one which gives the velvety appearance to the tongue. Okay, so it is diffusely present and it gives velvety appearance to tongue. And when we are talking about the taste buds, this is either like it is having no or few taste buds. So it is conical in position, and it is the one which is maximally present, diffusely present, but it is not having taste buds. Now next is fungiform. Next is fungiform. The fungiform is like, you can say it is like a club shaped projection. Club shaped, how? You can say club shaped or mushroom shaped, like this. It is club shaped or mushroom shaped. So it is a club shaped projection. And now what is its location? The location is either on the towards the tip, mainly on the tips, and on the lateral aspect of the tongue. So its location is, it is located at tip and at lateral margin of tongue. Okay, this is the location over here. And when we are talking about the taste buds, so yes, the taste buds are present. The taste buds, they are present, and its location over here is important, that it is present. For the circumvallate, we have mentioned it was anterior to the sulcus terminalis, and this one is at the tip and the lateral margin. The circumvallate papillae, when we are talking about the circumvallate papillae, we say it is the largest and it is about 8 to 12 in number. Okay, and the location we have already defined. We say the taste buds, yes, over here also it is present. And the fourth one is foliate, which we say is rudimentary in humans. Okay, this is rudimentary in the humans. So this is the introduction about the tongue over here. This is the introduction about the tongue over here. Then the next is the muscles. Okay, the muscles of the tongue. And now when we talk about the muscles of the tongue, we have extrinsic muscles and intrinsic. We have extrinsic and the intrinsic muscles. When we are talking about the extrinsic muscles, they bring about the movements of the tongue. It is for movements of tongue, and the intrinsic is basically to change shape of tongue. Now in the extrinsic we include genioglossus, then we have styloglossus, palatoglossus and hyoglossus. Okay, these are the muscles which are included in the extrinsic. And over here also, if you see, if you remember genioglossus, you can see glossus word for tongue. It is used for tongue, and it is also showing origin insertion. Styloglossus, palatoglossus, hyoglossus. So it is easy to tell about the origin and insertion of these muscles. Now talking about the intrinsic muscles, we say that it is for changing the shape, and as well as they have no bony attachment. These muscles, they have no bony attachment. They are basically the intrinsic muscles present inside, and in this we include like the vertical muscles are there, then transverse muscle, the transverse muscles. Then apart from this, you have superior and the inferior longitudinal muscles. The superior and the inferior longitudinal muscles. So these are the muscles according to its name. Vertical is present vertically, transverse is present transversely, and the longitudinal, it is present from anterior to the posterior aspect. So these are the various muscles inside the tongue to change the shape of the tongue. And for the movements of the tongue, mainly the extrinsic muscles are there. Now when we are talking about the extrinsic muscles over here, okay, now coming to this image, this is the image which is showing the muscles of the tongue. This is the tongue over here, and you can see a very important muscle which is forming the main mass of the tongue, and it is like going in this manner. Now this muscle is genioglossus. Okay, this is the genioglossus, and when we talk about its origin, the origin is from here, from the mandible, and the fibers, they are going up. Okay, the fibers, they are going up. So when we talk about the genioglossus, the origin is taking place from mandible, that is from the superior genial tubercles. Okay, that is the superior genial tubercles of the mandible, and the fibers, as you can see, they are going and inserting into the tongue. The lowermost fibers over here, they go and they get inserted on this bone, which is hyoid bone. So all these are the fibers of genioglossus. These are the fibers of genioglossus. Now coming to the next over here. Now the rest of the muscle fibers, if I say styloglossus, now this is the styloid process. Okay, this is the styloid process. Now from the styloid process, whatever muscle fiber is coming to the tongue, this muscle fiber which is coming to the tongue, this will be the styloglossus. Okay, this will be the styloglossus muscle fiber. Then the muscle fiber from the hyoid bone, this is the hyoid bone, and the muscle fiber which is going from the hyoid bone to the tongue, now this will be the hyoglossus muscle fiber. Then the another is palatoglossus, so that will be coming from the palate. If I say this is the palate, and this is the soft palate, and in the soft palate we say this is the palatine aponeurosis. Now the fibers which come from this palatine aponeurosis and they come to the tongue, this will be palatoglossus. So it is according to its name. Okay, it is according to its name. The muscle fibers are according to its name. So if we go back over here, regarding these muscles over here, if I talk about these muscles one by one, first is the genioglossus, which is a very important muscle. The genioglossus muscle, it is a very important muscle, and when we are talking about its origin, it is from superior genial tubercles of mandible, and insertion is into the tongue. Mainly it is in tongue, and the insertion can also be in hyoid bone, which are, we say, the lower fibers. Okay, the lower fibers are the one which are inserting over here. Now this muscle, the genioglossus muscle, it is considered as safety muscle of tongue. Okay, this is the safety muscle of tongue. This is a very important point, that this is a safety muscle of tongue. Why? Because actually the genioglossus muscle, it helps in the protrusion of the tongue. The tongue comes outside, and when it comes outside, it prevents the blockage of the airway and the food passage behind. So because of its action, that it helps in the protrusion, it acts as, it is termed as the safety muscle of the tongue. Now the other muscle is, if I say styloglossus, the other muscle is styloglossus, then for that we say origin, styloid process, and the insertion, that will be into the tongue. Okay, that is into the tongue. That is very simple. Then we have for the hyoglossus also, we can very well say origin from hyoid, insertion in tongue. The insertion over here in the tongue is at the lateral margin of the tongue. Okay, over here the lateral margin of the tongue, and for the palatoglossus also, the origin is from palatine aponeurosis, and the insertion is in the tongue. So over here in the tongue, they are actually coming towards the lateral margin of the tongue. They are coming towards the lateral margin of the tongue, and very important for these muscles is the action. Now the action of the tongue is that it can come out, it can go behind, it can be elevated, it what are the actions? One is muscles is the action. Now the action of the tongue is that it can come out, it can go behind, it can be elevated, it can be depressed. So what are the actions? One is protrusion, retraction. Protrusion when the tongue comes out, retraction when it goes back. Then elevation and depression. Okay, so these are the actions of these muscles, and these two actions are very important for us. And now when we talk about these two actions, the protrusion is by mainly the genioglossus. I'm just mentioning the main muscles over here. The main muscle, the main action, this action is mainly by genioglossus. Retraction is by styloglossus. Elevation is by palatoglossus, and the depression is by hyoglossus. Okay, so these are the basic actions which are produced by these muscles. Then we come to the nerve supply. The nerve supply over here is very important for the tongue. When we talk about the nerve supply, it is very important for the tongue. The nerve supply of the muscles as well as the sensory nerve supply. For the nerve supply, we say all muscles of tongue. Now this is very important. I'm putting a double tick over here. All muscles of tongue, they are supplied by hypoglossal nerve. So they are supplied by this hypoglossal nerve. And now over here also we are having an exception. Now what is the exception over here? Exception is except the palatoglossus. And when we talk about this palatoglossus, we say it is actually supplied by cranial part of accessory nerve. Okay, it is supplied by the cranial part of accessory nerve via pharyngeal plexus. Via the pharyngeal plexus. So all the muscles of tongue, they are supplied by hypoglossal nerve except this palatoglossus. I'm just adding a note over here. When we are talking about this pharyngeal plexus, it is also given the term as vagoaccessory complex. Okay, and this pharyngeal plexus, it is actually formed by the cranial part of accessory nerve plus vagus nerve. Okay, so this is what is pharyngeal plexus. Whenever we are mentioning this term, we mean to say that it is formed by these two nerves. So this nerve supply over here, which I have mentioned, was the motor nerve supply to the muscles. It was a motor nerve supply by the hypoglossal nerve. Next is the sensory nerve supply. Next is the sensory nerve supply, and when we are talking about the sensory nerve supply, then it is different for the different parts of tongue. For anterior 2/3, we say that general sensation of tongue is carried by lingual nerve. Now this is again very important, the sensory supply. And if I talk about the taste sensation over here, it is carried by chorda tympani nerve. Fine. So for the anterior 2/3, these are the sensations, and general means, like general sensation is touch, temperature, So such kind of sensations are general sensations carried by lingual nerve, and the taste are carried by cauda tympani nerve. For the posterior one third and as well as circumvallate papilla. Okay, for both of them we say both taste and general sensation is carried by glossopharyngeal nerve. It is carried by the glossopharyngeal nerve. And thirdly, we are having the posterior most part. For the posterior most part, again for this we say both taste and general sensation. They are carried by the vagus nerve. And in this specifically its branch which is internal laryngeal nerve. Its specific branch which is the internal laryngeal nerve. So the sensory supply is, this is the sensory supply of the tongue. This is the sensory supply of the tongue. And apart from this, if I talk about its arterial supply, so for the arterial supply, the main arterial supply is by lingual artery. As the name suggests, for the tongue, lingual artery. So lingual artery is the one which is mainly supplying, and apart from this we have ascending pharyngeal artery and as well as the facial. The tonsillar artery it is supplying over here. So the main over here is this lingual artery. The main over here is this lingual artery. Then apart from this, if I say it's lymphatic drainage, the lymphatic drainage of the tongue, then for the lymphatic drainage we say the tip of the tongue, it directly drains into the submental lymph node. Okay, it is directly draining over here to the submental lymph node. Over here the important is tip of the tongue. Then we say anterior 2/3 of the tongue, it drains into the submandibular, lymph node. And when we talk about the posterior 1/3 and base, then both of them they drain into the deep cervical lymph node. So this is the lymphatic drainage of the tongue. This is the lymphatic drainage of the tongue over here. Now next we will talk over here about the clinical aspect associated with this, which is hypoglossal nerve injury. And if the hypoglossal nerve injury is there, it will lead to atrophy of tongue on same side. Atrophy of tongue on side of lesion. As well as there will be deviation of tongue to the same side of lesion. Okay, so what happens over here is that if the hypoglossal nerve injury is there, on the same side the muscles are paralyzed and it leads to atrophy, and as well as there will be deviation of the tongue on the same side. Why the deviation of the tongue is there? Because if you see this image over here, this is the hypoglossal nerve injury. If I say this is the normal side and over here the injury is there. Okay, so what happens, the deviation is on the same side of the lesion. It is on the same side of the lesion because the normal side fibers, they become overactive and they push the tongue. They push the tongue, so thereby there is the deviation of the tongue is seen. Thereby the deviation of the tongue is seen. So this is about the hypoglossal nerve injury. Okay, now next we will be seeing this, let us see this sagittal section over here. Now if we see the sagittal section, before that, okay, in this sagittal section we can very well see that this is the palate over here. This is the palate, this is the hard palate, and this one is the soft palate. Okay, this is the soft palate, and this is the tongue over here. This is the tongue over here. Towards the most posterior aspect of the tongue, you can see there is a structure which is present over here. Now this structure is palatine tonsil. This is the palatine tonsil, right? So the palatine tonsil is basically towards the posterior aspect of the tongue, present on either side. It is actually present in a depression over here, which is given the term as tonsillar fossa. And this tonsillar fossa over here, you can see there is a fold on the anterior side and a fold on the posterior side. These folds are given the term as anterior fold and the posterior fold. The anterior fold is the anterior pillar or the posterior pillar. The anterior pillar is palatoglossal arch, deep to which the palatoglossal muscle is there, and posteriorly this posterior pillar is the palatopharyngeal arch. Okay, the palatopharyngeal arch is having the palatopharyngeus muscle which is present deep to it. So these are the two arches or the two pillars between which the depression is there, in which the palatine tonsil is present. Now when we are seeing the palatine tonsil over here, okay, if you see this view, this is the view to show the deep relations of the palatine tonsil. This is the palatine tonsil. If I see the palatine tonsil, it is present in this tonsillar fossa or depression, and towards the oral cavity side it is having crypts. These depressions which are given the term as crypts. So towards the oral cavity over here, it is having the crypts over here. So this is the palatine tonsil. And now when we see what are the structures in the deep relation of the palatine tonsil, we use the term as tonsillar bed. Okay, it is given the term as tonsillar bed. So in the tonsillar bed, the structures are, we are having this venous structure. We can see this venous structure which is paratonsillar vein. Then deep to it you are having this fascia over here. This fascia over here which is pharyngobasilar fascia. Then you have this muscle, superior constrictor muscle. Then deep to it you are having this fascia which is buccopharyngeal fascia. So you can see that one by one all these structures are there, and we say they are forming the tonsillar bed. Okay, they are forming the tonsillar bed. Then as we go deeper, you can see this muscle over here, this is chyloglossus, and there is an artery you can see which is present over here. This is the facial artery. So all these structures, they are contributing into this tonsillar bed. Now regarding the blood supply of the tonsil, we say the main artery which is supplying the tonsil is tonsillar artery, and the tonsillar artery is this one which arises from facial artery. Okay, this is the one which is arising from facial artery. This is the main artery, but you can see apart from this also it is supplied by other arteries like maxillary artery, lingual artery, and like ascending pharyngeal artery. So there are other arteries also which are supplying, but main is tonsillar artery. So when we are talking about this palatine tonsil, for the palatine tonsil we say it is present in tonsillar fossa. That depression is given the term as tonsillar fossa. And if I say this is the tonsil over here, on the oral side it is having the crypts. The crypts, they are present towards the oral cavity. Then in this we say, for the palatine tonsil we say it is having two pillars. It is having the two pillars. For the two pillars we say one is anterior pillar which is also given the term as palatoglossal arch or fold. Okay, and deep to it we are having a muscle. Deep to it palatoglossus is present. Okay, deep to it palatoglossus is present. And the second is posterior pillar, or we say the palatopharyngeal arch or fold. And now when we talk about this, so we say deep to it, what is present? Palatopharyngeus muscle. So deep to it you are having the palatopharyngeus muscle. And now coming to the tonsillar bed, when we are talking about the tonsillar bed, the structures which are present over here, we include paratonsillar vein, then you are having pharyngobasilar fascia, just deep to it superior constrictor, right? Superior constrictor. What was further deep to it? Buccopharyngeal fascia. The buccopharyngeal fascia, and as we go further deep, we have styloglossus and facial artery. So these are the structures which are present in the tonsillar bed. And then as we talk about its nerve supply, it is supplied by glossopharyngeal nerve. It is supplied by glossopharyngeal nerve. And if I talk about its arterial supply, then for the arterial supply, the main is tonsillar artery, which is a branch of facial artery. So main is the tonsillar artery, which is a branch of facial artery, and apart from this, it is also supplied by lingual artery. Then we are having maxillary artery, ascending pharyngeal artery, and also the ascending palatine artery. Okay, so these are the arteries which are supplying this tonsil over here. These are the arteries which are supplying the tonsil over here. Okay, I will be just ending the session over here, and the rest of the portion we will be discussing tomorrow. So in the rest of the portion now we will be talking about the nasal cavity, then we have soft palate, larynx, pharynx, right? These are the main portions, and as well as the ear. So these are the main portions, and after that we will just discuss briefly about the cranial nerves, because the nerves we have discussed a lot till now. So the other main points of the cranial nerves we will be discussing. So tomorrow we will be discussing all this portion. So I'm just finishing the session over here, and any doubt is there, you can ask those doubts. And tomorrow the class will be at 10 a.m. Okay. So and good night to all of you, and let us meet again tomorrow at 10 a.m. and tomorrow will be the last class. Fine. So tomorrow we will be having the last class. I'm just finishing the session over here. Bye, Soumya. Good night to you.